All right, good morning and welcome to day 2 of the Health Policy Commission's annual cost trends hearings. We're excited to have you all back here this morning for another thrilling and engaging day of healthcare policy and discussion. I'm David Self, the Executive Director of the Health Policy Commission. And on behalf of the board, I want to kick off today by just talking through a few of the key themes that we heard yesterday from our presentations and witness panels. So last night we prepared this slide, which is displayed on the screen here, around some of the key discussion points that we heard from the first day. And then I'm going to turn it over to our board chairman, Stuart Altman, to engage the board in some of their key takeaways from the day to kick us off. So first, just some reflections on the presentations from Dr. Ashish Shah, Dr. David Auerbach, and Ray Campbell. There was a great discussion around what are some of the drivers in healthcare spending in the United States compared to other developed countries, and really focused in on the issue of price as being one of the key drivers and differentiators of healthcare costs and spending in the United States. But Dr. Ashish Shah also, I think, highlighted the importance of addressing overutilization, and that it was not a uniquely American phenomenon, and that any efforts to address overutilization were also worthwhile given the very high prices of healthcare services in the United States. And he did highlight some promising innovations, especially in the space of payment reform, as well as accountable care organizations as being promising mechanisms for reducing healthcare costs while improving patient outcomes and quality. We heard from Dr. David Auerbach around some of the affordability challenges that remain for residents of the Commonwealth, particularly for lower and middle income residents who may see a large proportion of their total income being diverted to healthcare costs, leading to higher rates of outstanding medical debt. Despite a great deal of progress in other areas in healthcare spending with low overall spending growth, and some very promising trends for the first time in seeing community hospitals slightly tick up in the proportion of community-appropriate care that they were serving, seeing a continued decline in patients being referred to skilled nursing facilities after discharge from the hospital. But also areas where we haven't made as much progress, and particularly highlighted readmissions as an area where we continue to far lag the country. And I think David Auerbach said that we were the third worst state now when it comes to our readmissions rate. Dr. Ashish Shah also kind of laid out a dichotomy of different mechanisms for how healthcare systems can really provide value, and laid out two options in terms of greater government or price setting or regulation versus the promise of greater market competition, and made the case that in the United States we don't have much of either of those two mechanisms. Finally, I think all of the panelists throughout the day really did highlight the promise of alternative payment methodologies that, when effective, and can really change the incentives of organizations to focus on cost containment and patient outcomes. On panel number 1, which was focused on meeting the benchmark, we had a lot of discussion around opportunities to reduce administrative costs in the system. And commissioners pressed the panel about what it would take to actually not just reduce the cost growth benchmark or cost curve, but to actually see real reductions in healthcare spending that would translate into savings for consumers and businesses. We did have a great discussion, I think, among the panelists around the challenge of diverting care from academic medical centers to community hospitals, with some panelists saying that they had seen some success, and other panelists saying that this continues to be a significant challenge in an area where they are continuing to invest in branding, in education, and in clinical services at those community hospitals. We heard about the challenges that small employers in particular are facing with double-digit premium growth, and the trade-offs that they're forced to make in terms of wages and salary and being competitive in a global marketplace while still providing great benefits to their employees. We also heard a little bit around new innovative product design, such as tiered network products that may have a promise in terms of being able to both provide a lower premium point for consumers, but also steer patients to higher value settings of care. And then finally, on panel 2, which was focused on the growth in convenient and timely access to primary care and behavioral health care, there was, I think, a great discussion around how best to improve access to primary care and behavioral health care, with panelists talking about different strategies such as urgent care and urgent care that may be staffed with licensed clinical social workers. We heard from East Boston Neighborhood Health Center around their open access scheduling model, where 70% of the physician's time is set aside for people to be able to receive care when they need it, and that they had expanded that to behavioral health care. We also heard from the panel around efforts that they're pursuing to use technology and telemedicine to also provide a way of really enhancing access to care, particularly for challenging individuals that have challenges facing receiving care. We also talked finally about the role of electronic health records and their promise and the challenges with electronic health records, particularly with regard to physician burnout, and some of the strategies that panelists are using to address those challenges through other technology solutions. So those were some of the main themes that jumped out to us as staff after the first day, but interested in hearing from you, Mr. Chairman, and other board members around key takeaways that we should bring with us after these hearings.
Well, that's quite a great summary. So what I'm going to do is turn it over and ask each of you, if you want, you can pass. If you want to elaborate or expand the summary that David pointed out, then I'll start with you, Wendy, if you don't mind.
I don't mind. I've never had a professor tell me I could take a pass, though. So the things that I focused on yesterday were those statements and sets of experiences where the commission actually could do something in the next year. So I really tried to create a very short 3-item agenda that emerged from some of these comments that David just reviewed so nicely. So the first one of those is when Ashish was going through his list, which was fascinating. At the very end, he talked about the fact that we could really work to come up with different policy solutions for the pricing of non-innovative versus innovative drugs and devices. And I know that other people around the country have thought about this and talked about it, but as Massachusetts gets a little bit closer to thinking about how to solve the drug problem and the drug pricing problem, this is something where we might well have an opportunity to come up with some of those creative solutions. Second, Dr. Kreider asked a great question of the panel, and that was, why are narrow networks not working? And we know they're not working. We know there's been a very slow uptake of alternative payment models, particularly in the commercial sector. And I thought the answers were very thoughtful, which was across the board. By and large, it was people don't like them, and if employees are not happy with them, then employers are not going to offer them. So it brought to my mind the fact that as a commission, again, this is something where we could think creatively and imaginatively about what do we need to do to change the structure of these alternative payment mechanisms so that they are appealing to the consumers. And finally, I personally have a lot of enthusiasm for the power of telehealth and connected health and telemedicine. And so I thought the comments of that panel were fascinating, and it was helpful to me to understand what the barriers are to the adoption of a valuable, innovative technology that has now been around for 15 years. So not the EHR specifically, but other uses of telemedicine to improve access and improve quality. And again, because that's something that the legislature is thinking about, I think it's also a policy topic that the commission could take up. Thank you, Stuart.
Thanks, Wendy. David, we'll go back and forth.
Thank you, Mr. Chairman. I, too, thought the day was spectacular, and so congratulations for putting it together. I had a couple of different reactions to it. The first one is I asked both of the panels, kind of why have we not seen cost savings? And their answer, the answer of both panels, which I found fairly convincing, was we're actually doing a lot more stuff and prices are not going up. We're investing in care management planning. We're treating a lot more people with opioid abuse and other behavioral health disorders. We're seeing a lot more people with the same number of resources. We were understaffed in terms of physicians, and we need more physicians. So we're investing an enormous amount in the capacity to improve health in Massachusetts. And look, our costs aren't going up. And so I think you, as you think about this, should take that into account. And I actually found that, obviously there's no quantitative number associated with that. That's not the job of the panelists. But I actually found that to be a fairly convincing answer. And so that put me a little bit more at ease with respect to the cost trends than I had been before. My second observation is, in terms of the areas where we could do more, and I think as a commission we have not done enough relative to what we could do, is the area of administrative expense. And we've talked about it a few times, and I personally think I have dropped the ball in terms of bringing it forward more, and I think that it would be very nice for us to examine the issue of what we could do, particularly with price pressure on the sort of, we don't want you to raise your rates side, and cost pressure on the, look, there are new medications and there are people who were historically underserved and we want you to see them. Any relief we can provide to anyone, in providers, people in the Commonwealth, and so on, we ought to explore. And so, as I say, I personally think I have been remiss in not pushing it more, and I would like to bring it forward so that we can consider it as a commission. And then the third thing was just an observation, because I too was struck by my panelist, Dr. Kreider's questions about the narrow networks. There's an interesting dichotomy, which is that when people buy through their employer, the lowest common denominator seems to be a broad network policy. So that you need something to appeal to all of your employees, and that's a broad network policy. And yet when individuals are buying through the connector, almost universally they choose narrow network policies, with relatively few exceptions. And partly it's a difference in terms of the people, that is, higher income people are buying more through employers and lower income people are buying more through the connector. But I think it's also partly that individuals, when the employer is buying, don't necessarily associate all of the cost of the more generous policy to them, whereas when they're buying individually, they do. And so I was very encouraged by, in this case, the Secretary's comments about trying to make the connector be more hospitable for small businesses. And I wonder whether that is a way that we will encourage limited and tiered networks as appropriate for people. And if so, that might then provide an opening to where we can think about expanding that, or at least expanding the principles there to a broader share of the state population. So I was, Madam Secretary, very encouraged by that interchange as well.
Thank you, David. Madam Secretary?
There's a segue.
Good.
So a couple of thoughts. One is actually picking up some themes from Wendy and David Cutler. One is I thought the comment, particularly from Dr. Ferris and others around the reason you don't see the costs out is they have to invest in areas before you would see perhaps change in behaviors is one that I think as a commission, it's easy to say there's 30% waste in the system, and I wouldn't argue against that. But if you're going to really change a system, you have to invest in order to make the change. I almost made the comment that part of the Masshealth ACO restructuring, the hope of that is the fact that we have put in $1.2 billion in DSRIP funds to help in that bridging of investments in order to see hopefully changed practices and the like for savings. And that's like a 5-year trajectory. So we should really study that to see if that's effective. My worry on the $1.2 billion of investment is that it's actually used for the change management and not to offset current operations. But I was going to say that. Someone had asked why Cherokee Health, why East Boston and others had embraced Cherokee Health and why that worked. One thing I would point out, since behavioral health has always been an area of strong interest, is that the Cherokee Health System started as a behavioral health system that then added primary care, similar to the Lynn Community Mental Health Center that became a community health center. I'm starting to think that maybe if we really want to integrate behavioral and physical health care, we should start with behavioral health, and maybe primary care would come along. But for people who don't know why Cherokee was so able to figure out the structures of integration, because it started from a behavioral health space, bringing in primary care, just as a data point. The telehealth and telemedicine is why in a state as great as the Commonwealth of Massachusetts, which is like the epicenter of innovation and the like, why we have not more, what are the barriers that create or the unintended consequences that have not allowed for really maximizing that, particularly in areas where we know we have shortages. The other I would just sort of put out there, the two, is around, and it had to do with the first presentation, which is really pushing the value-based care models. They work, we see them work, and yet there is this anathema or reluctance to really keep that moving, and I'm not sure I have the answers to that at all. And then finally, perhaps I was, didn't have enough sugar at lunch or something. I was a little struck by the conversation around electronic health records and physicians feeling burned out by that. Quite frankly, I see that as a generational issue. I'm assuming that the current group of physicians coming in, they live on apps, they live in electronic health records. And quite frankly, as a patient, I almost said this to Tim, as a patient, I'm thrilled that my doctor has my electronic health record because I'm sick of answering redundant questions all the time. And for them just to be able to open it up, and there it is. So I have to say, I was having one of those like, well, wait a minute, I'm like that generation, so maybe I would prefer my doctor looking at me in my eye, but quite frankly, I want them to have all the data available to them so that we sort of talk about why it is I'm there as opposed to their burnout because they have to deal with an electronic health record. Now, I say that understanding that there's always technology glitches, but I was having a little cognitive dissonance over that part of the conversation. So those are some of my thoughts from yesterday, but I have to tell you, Stuart, we have to come back to readmissions. That was the one piece of the earlier presentation that
That's my line.
it's our line. It's our line together.
I think we can all join in on that line.
I have to say, in
We gotta find out
this
what's
great
going on, yeah.
Commonwealth,
We do
we
have to
should
find
be
out what's
ashamed that we have one of the highest rates of readmission in the Commonwealth. And perhaps we're measuring the wrong thing, but I just find that completely unacceptable, and no one in this room should accept that.
Thank you. Tim?
I'm going to carry you.
Yeah.
Thanks for the opportunity. I echo all the thoughts that were shared earlier, and my big takeaway from yesterday is get your questions and comments out soon in these discussions because a lot of it gets covered. It's a very smart and thoughtful panel up here, as well as the folks that have been joined with us throughout yesterday and as well as today. I was interesting thinking about my reflections on yesterday. I had the exact same reflection I had this time last year, which was looking forward to another great debate in the state legislature around how to address healthcare costs and ensuring that community healthcare providers can continue to provide care. I mean, so I thought that was my big takeaway in terms of the environment in which this conversation is happening, as it was happening last year, that look forward to another debate, and I'm sure everyone in this room is going to put all the time and effort and energy they put into the last one to try to get it across the finish line. So look forward to that. I think one of the other reflections I had was particularly around Dr. Berwick's question around what's happening to low and middle income, mostly middle income folks in the Commonwealth, and the cost of healthcare on them and their personal lives and the medical debt that it's impacting them directly. And how can we keep that in the forefront of our minds as we're continuing to have these discussions, I think, is what this is all about. And particularly the question around administrative costs and how we're getting a better understanding of that, with the dichotomy of needing to make investments to, as the Secretary just pointed out, to continue to increase quality of care and try to reduce costs, but at the same time, how do we get a control of those administrative costs with the eye of the consumer in mind, because of the real impact that has on people's lives, particularly folks that can't afford to continue to bring on medical debt the ways that they are. And so I think that was forefront of my mind after yesterday. Observation that I think was made clear, but want to reinforce too, is just better understanding the outpatient spending, contractual relationships of where that spending is coming from, where the patients are coming from, who's providing that care, at what cost, and the impact of the reduction of inpatient care, and how is that impacting providers across the state. I'm sure it's not impacting everyone the same, but I think getting a better understanding of both those, the impact of the inpatient decrease in spending and the growing outpatient, and kind of just understanding that the patient flows and the contracting relationships to get a better sense of it. And the other piece, building on that, is, and I've said this a number of times, is really getting a better handle on the long-term services and support spending. Again, I asked one question around the savings associated with directing folks out of long-term, nursing home facilities into home care, and what does that savings look like, to better understand that. But also, as we continue to see more spending in that space, and as we're moving to integrating long-term services supports into the Medicaid ACOs and other ACOs, I think us having a fuller analysis of what that means, and again, those relationships and referral patterns, and I think that's an important piece to understanding the total healthcare spending in our state and how the system is functioning. And so I think really digging in on that is an important piece. And so those are my main takeaways from yesterday, and look forward to a great discussion today.
Okay, Marty?
Thanks.
Thanks.
I have 3 takeaways from yesterday. I first want to congratulate the staff. I thought it was an interesting set of speakers and panel presentations, and I also enjoyed that we were hearing from new people. So I appreciate that. My 3 takeaways: one, to add to Professor Cutler's remarks, I was struck by the issue of administrative costs, and I think it's something, I think this is my 5th cost trends hearing, and it's really the first time we've had the discussion here. We've had it at several board meetings, but I think it's something that truly there's an opportunity to focus on going forward. I would add the rehospitalization rates, but that's been already articulated so well. 2 other issues for me. It was interesting. We were starting to hear, we heard from several folks about relationships with police and schools and housing, and so it gets to the social determinants of health, but it's almost of an add-on. It's not really yet something where people are saying that there's an important opportunity here, and we're focused on that. And Dr. Cha had some important remarks in that regard as well. I think that's clearly remains a place for opportunity in terms of our thinking, partly in our demonstrations with some of the grant programs as well. I remember at the conclusion of last year's cost hearings, I think the Secretary made the observation, and I agreed with her, that the promise of primary care and behavioral health integration remains a promise and wasn't fully realized. And I was struck yesterday that we had two very good examples, Manny Lopes from East Boston around the Cherokee model that he's using, Ed Moore from Harrington about the comprehensive network that he's developed. But yet we also heard from Norm DeShane, who said that that remains one of WellForce's sort of issues going forward is primary care and behavioral health integration. So I was left, and also picking up on, I think, Ed Moore's remark about how fragile that system is, that, as he has to look at other costs, those low-margin services are maybe vulnerable. And, that shouldn't be the state of primary care and behavioral health integration. So I think there's still more work to be done in that area as we think about the Commission's work going forward.
Ray, would you like to add any comments?
Sure, I'll just offer just one quick comment, which is I think we did a great job yesterday. Yesterday's discussion really highlighted what a great job the state does using data to inform its public policy discussions. And I just wanted to highlight the fact that I think in the future what's going to become even more important is using multiple data sets to look at a particular issue. And I think Chapter 55, the work that we did in that area, is a really good example of using, bringing together many different data sets so you can start to look at the social determinants of different issues. So I think that as we start looking at cost trends and we look at the things that are driving the cost trends, I think in the future it's going to require and involve more and more multiple data sets being brought together to answer some of these questions. And we'll just do a shout out to the Department of Public Health here in Massachusetts. Their public health data warehouse is an attempt to take what was done with Chapter 55 and kind of replicate it in a sustainable or kind of an ongoing way. And it's, I think, a really breakthrough project, and CHIA is involved in it, really supporting it. I just wanted to sort of do a shout out to that concept of bringing multiple data sets together in order to study a problem.
Very good. Dr. Craig?
I think we heard over and over again on the provider side how the contracts that they're doing in alternative payment models are de minimis, and there is administrative cost to managing them. And I think we heard, at least I heard, that the movement toward global contracts, real risk contracts, isn't here yet. And until we get there, we're not going to see reductions in costs. I mean, around the country, providers are becoming payers. If you want to see administrative costs decline, you've got to have the providers take both clinical risk and financial risk and simplify this spaghetti of claims-based payment system, a claims-based fee-for-service payment system. I'll just make one other comment about the electronic medical records discussion. And I don't think it's generational. Maybe that's my age. But there's a burnout phenomenon, certainly among older physicians rather than younger physicians. But I do think consumers generally, for some patients, it really works. And for you, it really works, Madam Secretary. But I think there's a difference between all the data and the data that matters. I'm not talking about macro data that Ray mentioned. I'm talking about systems that accumulate so much stuff that there's too little listening, there's too little understanding, there's less empathy, and taking care of patients is hard. Being a patient is hard, and these systems, by and large, were designed for financial, accounting, and billing purposes, not for clinical management. And then to take that conversation and circle back to the plight of community hospitals and pricing variation. And until we start to narrow the gap between the rich hospitals and the poor community hospitals, we're going to struggle with the EMR problem. And it was manifest, I think Tim Ferriss said it pretty well. He said, before I had the additional resources that MGH provided to me, I was spending 4 hours of clinical care and 4 hours of documentation. And now, because of the resources that MGH has provided to me, I get 4 hours of clinical care and about a half hour to document what I've done. And the rest of the panel were just almost physical in their reaction because they don't have the resources to be able to do that. So it's a it's a complex issue, but on balance, I think it gets back to pricing variation. I do think the technology is going to fix itself. I think Tim is right on that score. I've said enough.
Thank you. Eric, would you like to add?
Thanks, Dr. Hellman. Just quickly, you'll hear from the Attorney General and my colleagues in a few minutes, but I was struck yesterday by Dr. Jah's sort of what are the two main drivers of healthcare costs that we've been talking about for a number of years, price and then administrative costs, and that there's still a lot of work to do on price and also sort of new work to start on administrative costs.
Thank you. Ron? Thank you.
To not repeat what my colleagues said, I'd like to focus on a key point that I think Ray brought up earlier yesterday, and that's the fact that 28% of us are in a high deductible policy. In addition to that, our deductibles are continually going up as well, and it becomes more of a burden for average residents of the state. But we still have a transparency problem and an education problem in terms of having us, as consumers of medicine, really understand what we're purchasing when we're purchasing insurance. And that applies to small companies as well, as we were discussing yesterday. I see very little in terms of education and making me feel comfortable when making that decision. I think it's critical that we start doing that. A second point that I'd like to raise is we were briefly talking about community hospitals. The big issue I see in that environment is, although we've found there's some stability now in terms of utilization at the community hospital versus the academic settings, unless they rebrand and come up with an innovative, competitive business model, they're not going to be in business. And it's critical to us to have them survive and to succeed. But they truly need to rebrand and become innovative. And one last point, I mentioned to a few folks before we started this morning. In my office, they were live streaming the cost trend hearing. And one of the folks in the office said to me, you know, I was watching it while we were working, of course, while we were working. And and they said, I was really concerned. So I said, why? All you care about is cost. I said, no, it's a cost trends hearing, right? And she said, yeah, but what about quality? So you know something? I think it's a good point. I know everybody on this panel is concerned about quality, as we all are, but I don't think we really need to also stress that as we're looking at the various topics. And I think it's important because to have someone who hasn't been involved to see something like this for the first time, and she actually said, and this is a quote, I found that scary. It's interesting. Thank you.
Sorry to have you last, Elizabeth, but you get to summarize no, I'm going to go to summarize everything. I'm going to go last.
First, I will say, great day, so thank you, David, and to the HPC staff. 3 quick points that have been largely covered by my fellow commissioners. One, I do think we need to drill down on alternative payment methods. We talk about it as a monolithic thing, and I think Dr. Jah highlighted that there are good forms of, there's good reform and then there's bad reform that has been shown to be less effective. And I was particularly struck by David Auerbach's slide on the variation by payer, and I want to understand why that's the case. Is it because Blue Cross Blue Shield has market share that they're able to adopt these alternative payment methods? And I want to understand more about how we can incent downside risk. Second, I'll echo Ron's thoughts that I think we need to drill down on high deductible plans and consumer education. Are consumers choosing them because they only know the upfront cost of the premium? And how can we inform them better about the out-of-pocket costs? I was really interested in the tool that I think it was the partners had where you could enter information and choose your plan based on the types of diagnoses that you have. And obviously that, again, showed how there's the haves and have-nots, and it didn't exist across all the panels. And third, I wanted to add one point to Dr. Cutler's view. He, as you pointed out, there are that employers are not don't offer the narrow network plans as often and we see it on the connector that there's a lot of adoption, whereas employers don't. And I think we need to add the GIC to that conversation, because that is one case where an employer is offering narrow network plans where there's a high adoption rate, including myself. So I would add that. Thank you.
All right. So let me take a little different tack then. Particularly, David, it's very, with some hesitation, I want to take on a Harvard professor, but Brandeis has its own strengths. So I'm sorry, I didn't come away feeling warm and fuzzy when I listened to the reason why healthcare costs and prices have to keep going up. So I've heard this tape before. I heard it in the 70s, I heard it in the 80s, I heard it in the 90s. God, I can't. In the 60s, yeah, maybe even in the 60s. You know, one of the things that I've learned in life, in healthcare in particular, it's like the running of water. If you try to block it at one level, it goes to another level, and it goes to another level. So we need to not be carried away. I don't care what it is that's doing good things, whether it's technology or changing this and that. If we don't keep our eye on prices, your original question was absolutely the right one. Why aren't prices going down with all these efficiencies? Now, it is true that the trend lines are lower, and that's a good thing. But this idea that somehow it's all inflation, and I'm so sorry I didn't push Tim harder. It's not just inflation. Wages are going up much faster in healthcare than in any other sector. If you look at the number of people I'm sorry, what we heard at the end of yesterday is just not true. The number of people, whether it's administrative people or nurses or doctors or others in healthcare, is growing at twice what it is in other areas. So I'm all in favor of the good things that are being done to make our system more efficient. But if we're not vigilant in making sure that at least some of those go in the form of lower prices, what it will wind up doing is just spending money on something else. So I think we need to keep our eye on both sides. And I want to go back, maybe it was just what I said to Ashish. In other countries, they are not more efficient than we are to begin with, and left alone, they would do exactly what we do. The reason why they spend less money is they spend less money because they have no choice. They face tough budgets, and they are forced to take some of these efficiencies in the form of lower spending. Now, we don't have budgets. I mean, when you think about this $3.3 trillion industry, we realize there are no budgets at the end. There are budgets in the health budget that the administration and the state is trying to administer, but they have a tough time. There is somewhat of a budget in Medicare. So my final plea to us all is, while we push for these efficiencies, let's see some of those efficiencies turn into lower spending. And that's, Eric, I couldn't agree more with what you said and that, whether it's us, the Attorney General, the state, prices matter. So with that, I think it was a great day. And I really, again, want to thank David and the staff for putting together a phenomenal. So that gives us a little reason to continue our functioning in this job. So I'm now going to turn the program over to the next part of it. I'm turning back to you, David. Secretary. All right, and you're going to then, Secretary, you're going to do the intro. Ping pong. Yep.
All right, Trish, come on up. It's my privilege to formally introduce Trish Reilly, who is the Executive Director of the National Academy for State Health Policy. And if you don't know about the National Academy of State Health Policy, shame on you. I think you have her formal bio, but just I'll give it briefly. She was a distinguished fellow in state health policy at George Washington University and taught in the graduate program at the Muskie School of Public Service in the University of Southern Maine. She has had government experience as the director of the Governor's Office of Health Policy and Finance in Maine and leading the efforts to develop a comprehensive coordinated health system. And she was the principal architect of the Dorigo Health Reform. She has chaired the Governor's Steering Committee to develop a plan to implement the Affordable Care Act in Maine. Obviously, she's a Mainer, in case you can figure that out, and has held appointive positions under 5 Maine governors. She was a founding member of the Medicaid and CHIP Payment and Access Commission, and she holds a bachelor's and master's from, any guesses? University of Maine. But most important, what I'd like to say about Trish and the National Academy for State Health Policy is that it is nonpartisan. It provides a unique forum across all levels of government, executive, legislative, and other players, policymakers and others. The National Academy offers a safe space at both in small meetings and at the national conference for 2 things. One is the breadth of participation and the breadth of participants who come to both the small and the larger conferences, and the depth of analytic and problem solving. So I think that really speaks to both the Academy, of which you are the executive director, and how you have come to view and analyze and think about and innovate around healthcare policy, because as you have always said, not one person owns healthcare policy. All of us own healthcare policy. So welcome and thank you for being here today, Trish.
Great. Thank you. Thank you very, very much, Secretary. And I have a confession. I was born and raised in Massachusetts.
Well, we knew that too, but we're going to let you say that.
Chairman Altman, Vice Chair Everett, members of the commission, I'm very honored to be here. The work of the commission is very well known by states and followed closely. I think you're making groundbreaking efforts here, and I congratulate you, and I'm truly honored to be here. And the Secretary has nicely summarized my next slide, so we can move right on. NASHB has been around for about 31 years, and we're very, very pleased to have, as part of our membership and steering committees that guide us, 3 state officials here, Luis Gutierrez, Dan Tsai, and your own David Seltz, and many staff people who participate with us in small groups, including Secretary, who's been very, very active with us. So thank you. I've been asked to sort of walk us through generally where other states are, how Massachusetts and the Commonwealth work places among state activities. And David asked me a couple of specific questions, so I'll try to answer them. You know, what motivates states to act? Obviously, the budget. Increasingly, the budget is challenging. States, except for 1 or 2, have to balance their budgets. And the sort of inexorable growth of healthcare makes that so very challenging. Much of the discussion around the states has been around Medicaid, since it comprises about 25%, state and federal, of state spending. But in fact, states spend a great deal of money in corrections, public employees, municipal, university faculty. There's lots of state funding, often done in silos and not coordinated. Obviously, states have great oversight responsibilities for at least part of the insurance market, and the high cost and high deductibles have driven lots of attention. And I want to spend just a minute, because states have indeed been the laboratories of innovation. There's been much attention to the extraordinary work here in Massachusetts as it guided the Affordable Care Act, but that's a long tradition in states. 26 states had enacted the Children's Health Insurance Program before the Congress enacted CHIP. States had enacted mental health parity laws before the Congress enacted mental health parity. Gag clauses that were just signed by the president have been passed in 26 states before they became part of the federal attention. So we think all of the areas of costs, states have a particular role and a unique role in that states can move more, can be more agile, can be more facile. When we make mistakes, we can fix them quicker. When we need to refine and reform, we can and do, and I think that's important. And of course, it's the public outcry that gets public attention, particularly at the state level. And here, this slide I think is particularly important. It's a little bit dated, it's February 2018, but the Kaiser Family Foundation asked an open-ended question. I think that's what's important about this. What healthcare issue do you most want to hear candidates talk about? Now, most of us are probably tired of hearing candidates talk at this late stage in the debate, but nonetheless, it's stunning to me that 22%, the highest single area, was healthcare costs. The public gets it. The public wants action. And for states, that's particularly important since 36 governors are up, 17 open seats, 80% of all legislatures are up for election. So we will likely see some change, and we have very most definitely seen healthcare play out in those races. The frustrating thing for some of us in state health policy is we've been at this work for a long time, trying to bend the cost trajectory. And despite the successes of much of that work, the trajectory keeps rising. Payment and delivery reforms, much of it fueled by CMS and CMMI and big federal investments, many of which have been part of the Massachusetts work, have been really important in states. Global budgets, sustainable growth rates, rate setting. Many states, Massachusetts, Maine, had rate setting for many, many years for hospitals. They fell by the waysides. Maryland has continued, perhaps because it was a state that had a Medicare waiver and was truly all-payer. More attention, again, is being riveted at rate setting as a potential vehicle for reform. There's cost market oversight responsibilities in the states. 23 states have already passed surprise billing laws. There's great interest in the work here in Massachusetts with your determination of need in an increasingly consolidated healthcare system. What do we do when the market forces us such that those big consolidated systems have such power? How do we think about some of the state structures? Does CON need to be redone? Transparency has long been a tool of the states. Several states, Washington, New Hampshire, and Maine, have pretty successful used their all-payer claims database, and I think work is underway here, to do cost compare websites, where you can go to a website, look at the cost by payer, by facility. It's a beginning. Some of the interesting trends that I think have grabbed state attention, one is reference pricing. There's been a good deal of activity, particularly around state employee benefit plans, California's CalPERS, where for shoppable activities, if one is to choose the lower cost, but still I'm sure high quality, colonoscopy or mammogram, then you don't pay a copay. So changing employee behavior by inducements around copays. In Montana, they were experiencing a really serious budget problem with their state employee health plan. They negotiated with the hospitals. They decided that they would do reference pricing with Medicare and that they would follow Medicare payment methodologies. They would do Medicare Plus, and they would pay all hospitals at that rate. And they were able to save $15 or $16 million, which in Montana is real money. And states have interest in that. It also simplifies some of the billing procedures by tracking what Medicare does. Increasing attention, given that there are the silos of funding within states, that so much attention has driven by Medicaid because Medicaid spends so much money. But increasingly, states have begun to think about their role as public purchases writ large. So we see in Washington, the Healthcare Authority combines Medicaid under one roof. Medicaid and state employee health plans will soon bring teachers under that. The Oregon Health Authority purchases care for 1 in 3 Oregonians. And it does so by covering Medicaid, public employees, teachers. And they're now holding that plan to a 3.4% growth rate that they hope to expand into the private sector. Tennessee has adopted episode-based payments across state employees, retirees, Medicaid, and I think this is one promising area of experimentation by the states. Many ask, why focus on pharmacy? It's the smallest part of the pie. But I think, as you've all seen and we all know, it's the fastest growing part of the pie. Importantly, it's one of the places where we can really look at prices. The issue with the pharmacy issue is the black box of how prices are set. Unlike every other part of healthcare where we decide what we pay, where we determine payment rates, in the pharmaceutical world, prices seem to be set by what the market will bear. It's very much a black box and one in which states want very much to engage. So clearly, it's an area that has grabbed a great deal of state attention and is a big part of our work as a result. The biggest driver, I think, for states, again, recognizing their balanced budget requirements, is not just the incredible launch prices that can provide sticker shock to anybody who's a buyer, but the unpredictability of increases throughout the year. And if you're trying to balance a budget and a drug that's already costly goes up significantly, it's a tough thing to deal with in your budget. Obviously, even people with only remote understanding of healthcare have heard about specialty drugs, biologics, immunotherapy, extraordinary innovations with extraordinary promise. And yet it raises the specter in the states of how do we balance their extraordinary capacity to really help people against our ability to pay. So this clearly is an issue that has grabbed state attention. The 21st Century Cures Act fast-tracked drugs, making them more readily available without the kind of testing for efficacy that drugs have been required to pursue in the past, more expensive drugs on the market more quickly. There is also no federal consensus, despite the president's effort around the blueprint and much discussion federally. And states simply can't wait. States don't wait, they can't wait, they need to act, they need to experiment, and they are doing so. Our work with the states is designed in part to disrupt a business model that appears to be out of control, a business model that's very costly, and that where we again, the balance, no one disputes the extraordinary innovation that's going on in the pharmaceutical industry, but the balance between what we can afford and what that price is and whether the price is appropriate, it's a question that's difficult to answer. And finally, for us, as the Secretary noted, we are a bipartisan group. The majority of governors, the vast majority of governors today are Republican, and we are very much committed to bipartisan solutions. This is an area that enjoys strong bipartisan support, that people really do want to attract, to attack the issue of these costs. We have created, as a result, a Center for Drug Pricing with support from the Laura and John Arnold Foundation. We have a work group that David sits on, and we're working hard to try to give states the support they need to engage in this issue. And engage they will. In 2018, we saw far more bills introduced in state legislatures than in 2017, and that's important because in 2018, these were short sessions in most states. Most states have only a couple of months of legislative session. In 2018, several states didn't meet at all, yet 170 different bills were introduced. 28 states passed 45 new laws. Those were largely around pharmacy benefit programs with 31 laws, and I just list a few states to give you a sense of the bipartisan interest here in this issue. 26 bills on transparency were passed, 7 are in law. One state passed a bill to do wholesale importation of high-cost drugs from Canada, Vermont. Utah's close to doing so, passed it in one house, and will reconsider it. We believe the legislature ordered a study to reconsider it this year. Maryland passed a price gouging bill. 13 other states proposed them, and 3 bills were proposed for rate setting. Let me quickly take you through what those look like. Here's a snapshot of the transparency laws. As you can see, most states are looking at manufacturer price increases. Some look at health plans. There's a variety of looks here. The launch prices are of keen interest. Interestingly, the state of Nevada has a provision, uniquely theirs, that requires patient groups, nonprofits, to identify whether they are funded by pharmaceutical manufacturers. A Kaiser Family Foundation, and it reflects, I think, the findings of a Kaiser Family Foundation, that in 2014-15, I think, which was the latest the data was available, looked at 14 companies. They spent $116 million supporting 594 patient groups around the country, which pales against the $63 million they spent in federal lobbying. So these are initiatives that are supporting consumer groups, and Nevada wants to know who, and asked as part of their transparency bill for that information. Vermont was the first state to pass a transparency bill and amended it last year. Like many of them, it asks health plans to to report on the most costly drugs, the impact of drug costs on premium rates, and asks manufacturers for information on price increases and high launch prices. So again, the issue here is not to suggest that pharmaceutical manufacturers shouldn't make money on the drugs that they have invested greatly in. It's what's the right rate? What should we be paying for these drugs? California's bill is very comprehensive. Like Vermont's, it has much of the same provisions. It adds the requirement for manufacturers to give 60-day notice, advance notice of price increases. Again, states are struck with the unpredictability of cost increases. This helps with that budgeting mechanism. And let me just quickly go through all of them. As is the case in many of these situations, there is disagreement between the industry and the states about what ought to be done or whether we should address these costs and what ought to be done if we do. And the industry filed suit against California, arguing that it would cause all kinds of disruption. It has three major provisions. One is the Commerce Clause, which prohibits California from regulating drug pricing beyond the state's borders. This is a key area of concern in this whole pharmaceutical pricing issue. We can't set prices, and we can't impinge upon the industry's ability without violating the Dormant Commerce Clause. The First Amendment, arguing that they compelled speech through manufacturers justifying price industries and due process because the law is unconstitutionally vague. The case was thrown out by the district court, arguing that it failed to show that the court has jurisdiction to hear the case. The judge, however, gave Pharma 30 days to amend the complaint after finding its initial claim that California's law attempted to dictate national health policy without merit. On September 28th, Pharma did refile, and we'll keep a look at that and see what happens there. Connecticut has a very robust transparency law that they are developing now, and I think points out again the importance of insurance regulators at state government for having a role here. Insurance regulation has historically looked at how rates are set by insurers, holding confidential proprietary information. Here, too, health plans are asked to report how they impact premiums, and I think there's a dual responsibility here. One, you have the transparency of the information. Two, you have the insurance regulator who can then use that information in rate review, one would assume. New Hampshire and Maine are likewise studying transparency and have to report back to their legislature in 2019. We have convened the states that are engaged in transparency to try to standardize the effort, to try to have a searchable database, to try to build on each other and be able to do analytics across these states. But importantly, transparency is an essential but inadequate step to address pharmaceutical pricing. We need to know what's inside the black box. We need to get this information. But alone, transparency, I think, will not bring down costs. That's why we see some efforts beginning around the states to take on the price issue. Maryland enacted the country's first price gouging bill on generic drugs. It was immediately, the Association for Accessible Medicines, the generic trade association, filed suit, claiming the law could hurt competition, drive up prices. And the Fourth Circuit Court of Appeals found the law, in fact, regulates trade outside Maryland's border and thus violates the Dormant Commerce Clause. The Attorney General has recently, I believe, announced that he will appeal yet again, but this is an issue of interest among the states, and I'd point out 13 states knew that this bill was being challenged in the courts, yet introduced the bill. And I think that's the nature of the states. We expect these bills to be challenged, and yet states keep pushing to see if they can advance and test with reform. But importantly, the price gouging bill looked at prices, and that triggers all kinds of legal issues that there are all these lawyers behind me. I don't pretend to understand them, but it's a challenge. So the sort of new approach is, how do we look instead at what we pay? Not what they set the price at, but what we pay. Again, we set rates for hospitals, we set rates for other providers. Can we do the same for pharmacy? Maryland passed in the House, but failed to do so in the Senate, a rate-setting bill that would basically establish, not unlike rate-setting did in hospitals, establish standards for spending in the state by all payers. It's being revised and reconsidered, and we expect it to see it advanced again this session. It's been renamed, and I think properly so, the Prescription Affordability Board. This model follows a public utilities model. We regulate public utilities in states. There are drugs that are public goods. We're not suggesting all drugs, high-cost drugs that are public goods, and there may be a model here to look at payment. Minnesota proposed a similar bill, and New Jersey has a bill in the pipeline as well, and we expect to see some more introduced in 2019. Vermont has taken a new approach, and this to import drugs from Canada, where prices are significantly lower than they are here for the same drugs. Given that drug manufacturing has become a global industry, 40% of drugs now sold in the United States are made someplace else. 80% of the raw ingredients in drugs in the United States are made someplace else. 30% of wholesalers in Canada are FDA licensed. So the industry is itself global, the supply chain. And Vermont passed, Utah will reintroduce a bill to import certain high-cost drugs from Canada in a wholesale importation. This is not personal importation where there have been some problems. This is a wholesale importation program where a wholesaler in Canada sells to a wholesaler in Vermont and follows the current supply chain. And Vermont is actively engaged now. The federal government does have the authority by law to grant a state permission to do this if they can assure savings and safety. You spoke yesterday about alternative payment methods. This is an area, again, of interest in states. In Louisiana, they're advancing an alternative payment model for Hep C drugs that they call the Netflix model. It's a subscription model with a flat price negotiated with the industry to provide drugs in exchange for open access for all who need the drug. Medicaid initiatives remain terribly important for the states because of the extraordinary amount of spending, given who's on Medicaid. These are populations who use a great number of drugs. And so there's a clear interest here among the states. It's really a tough nut to crack, as no one knows better than Secretary Sutters, because generations ago, decades ago, a grand bargain was struck with the federal government and the industry, in which the industry agreed to significant rebates at the federal level and allowed states to achieve supplemental rebates in exchange for every drug being offered on the state's formularies. States have some tools, prior approval, preferred drug lists, but they're very limited, and every drug must be offered. The industry assures us that the Medicaid program gets the best price. The challenge here is that only CMS knows what those rebates look like. I was a Medicaid director, and I remember being told, we were very proud of our supplemental rebate program. I remember being told that on a certain drug we got the best supplemental rebate. And then talking to my colleagues in other Medicaid programs who told me for the same drug, they got the best supplemental rebate. And it's a black box. We don't know. CMS knows, but it's a tough place to negotiate, as Massachusetts has found. There was extraordinary interest in the waiver that the Secretary and her colleagues advanced, very creative, a very middle road, we thought, and states were keenly interested in it. It was denied, as you well know, and I think all eyes are on Massachusetts to see what your next steps will be. New York has also created an interesting approach to its Medicaid pharmaceutical pricing. Complicated but interesting. It basically has established a budget for its Medicaid program and a budget for Medicaid drug spending within the Medicaid budget. When that budget is exceeded, the state identifies those drugs that are high cost and that have broken the cap effectively. And they negotiate with those companies to see if they can get, if you will, supplemental, additional rebates to bring their costs under budget. And they succeeded with many drugs this year when they broke the cap. One company did not negotiate it. It was a single-class drug for a cystic fibrosis and would not negotiate an additional rebate. The state did not have the authority to say we will not use that drug, and of course people needed the drug. It has created a series of transparency requirements when company manufacturers will not negotiate drugs, and we'll see how that plays out in New York, but asks for more information about how prices were established in the instance where they are not able to get that change. Alternative payment methods, we are happy to be supporting Oklahoma and Colorado through our Arnold Foundation funding. Oklahoma has the first in the nation alternative payment arrangement with a drug manufacturer. This is an area where the drug manufacturers in the states have found some harmonic convergence. There's some agreement, there's some interest on both sides to really look at this. Although it took Oklahoma negotiating with 20 to 30 companies before they found one or two who would be interested in engaging with them. Basically what happens is the manufacturer agrees to a set price. The expectation is that performance metrics will be established, and if the metrics are not established, there are additional rebates paid back to the state. The first drug that had this APM in Oklahoma is an injectable, long-acting antipsychotic. And the argument is that it will increase adherence for those who use the drug, lower hospital use and emergency use, and therefore both sides benefit, and we will wait to see what happens. In Colorado, they're looking at an area that has not gained much attention to date. Much of the work that we've been engaged in with states have been outpatient drugs. In Colorado, recognizing that inpatient physician-administered drugs are often very expensive specialty drugs, chemotherapy drugs, and they're examining ways to restructure the payment for those drugs. The first step of which was to survey, which they've completed, physicians to get a better handle on how exactly those drug prices are established. So again, an innovative approach worthy of review. So I think our next steps is we will see more action from the states. It's tough work. It's a little like, pushing that rock up the hill. It rolls back over you, but you get up and push it back, and that's what states seem to be doing here. And again, it is interesting that 28 states with great diversity, red, blue, purple, have passed gag clauses, assuring that pharmaceutical benefit manufacturers must pass on to consumers the savings that consumers are eligible for, or information. If the PBM price is higher than what a patient could pay out of pocket, the pharmacist now is allowed to tell the patient that. New England has been very actively engaged on the pharmacy issue, and we very much would look forward to working with you should the Commission and the executive branch and the legislature want to pursue these efforts. It's hard work, and I think there is always value in states working together. So thank you very much.
Trish, thank you so much. That was wonderful. So we have a couple of minutes until the Attorney General comes, and I don't want to hold her up. But so if there are questions of Trish, I would welcome them. Elizabeth?
First, thank you. That was a fabulous presentation. Could you expand upon the types of laws passed regulating PBMs?
Yep. The PBM, they're a little bit all over the place because that's what states do. They tend to be gag clause laws. They often license PBMs. They have not. Some states have had some provisional certifications, but they license them. And there's a good deal of requirement around transparency, largely transparency about rebates, at least in aggregate. Again, recognizing that some of this information is proprietary.
Secretary?
Can you just, I know there's a lot of buzz around Oklahoma, but it's my understanding that no high-cost drug companies has actually come to the table. Could just be the buzz among states, but that's sort of my understanding.
That's correct. 20 or 30 companies they spoke to before they got 2 small companies to participate. I think there are concerns about the data. There's concerns about the metrics of how you measure this. There's concerns on the other. There's considerable skepticism on all parts, I think, and among some from the state perspective about can we get good enough metrics and good enough data. The exchange here is often to open up to everyone access to a drug that now may be prior approved, may be on a PDL, it may not be, and there's questions about what the trade-offs are. I think it's very much toe in the water work, and we need to sort of see, but it is correct that the big companies, some of the big companies expressed interest in working with the state to examine utilization and get a better handle on what an APM might look like. Mm-hmm. So there may be some future work with bigger companies.
Thank you.
Tim, I'm going to give you the last question.
Well, thank you very much. Just a quick question. Given all this, what would you say would be the right, no rate of growth is clearly the best outcome, but what would you think we should be seeing if if we implement some of these things and there's a bill passed that tries to address the issues you've raised, what is a fair rate of growth that we should be seeing in pharmaceutical spending?
Next question. I think we don't know. I think part of the problem is we don't know what these prices are made, how are these prices determined? What is a reasonable rate of growth when we don't really have a good sense of what the underpinnings are, that what goes into them? We hear a lot about R&D costs and what states have, many of the states have shied away from that work. Because it's so complicated. A molecule is used for multiple drugs. How do you measure that? And instead looked to ask, how do you make that determination of launch price? How do you make that determination of a price increase? When is it? And I think until we get some of that, again, I think that's why transparency is the first important but inadequate step, because we need to better understand so we can make fair and rational. These are emotional issues in the states. They're drugs people very much need and want. They're innovative, exciting. Companies are doing great work, but the prices are out of control. So I think that is the million-dollar question about what is a fair and appropriate rate of return.
Well, what a great way to end, which is it gives us a little something to do. I think it ought to be on our agenda for next year, David. And what is a reasonable price? Again, I want to thank you, Trish Reilly, for doing a phenomenal job. This is keep it up. Well, we're so honored this morning that the Attorney General, with the incredible workload that she has found some time to come and visit us. So it's such a pleasure for me to introduce Attorney General Maura Healey. As I was driving in this morning, there was something that you were doing with energy or something. It's amazing you find any time to find healthcare in your agenda, but I know you do. And, I want to personally thank you and your staff for the kind of work you're doing in the whole healthcare area. And it's so pleasing to me, the good cooperation that exists between your office and the Health Policy Commission. And I know I know you have the best interest of the state at heart, trying to balance that complicated issue of high-quality health care with reasonable and affordable prices. So again, I want to thank you so much for taking the time and addressing our cost trend hearings. It's a pleasure to introduce you, Attorney General Maura Healey.
Well, thank you very much, Stuart, and thank you for the compliment, although that is entirely a credit to the team on all fronts, whether it's energy or consumer issues, and certainly with respect to healthcare. And I'm lucky to have the team that we have in the office, and I look forward to their presentation a little bit later, but I do appreciate the opportunity to personally come and thank you as a commission for the work that you do. Thank you for the continued partnership. I appreciate all of your efforts. Thank you, Stuart. Thank you to all the commissioners for your commitment to improving health care for all of our residents. I'm honored that Marty Cohen and Dr. Berwick and Dr. Cutler are serving on our behalf out of the Attorney General's office on the commission. Good morning to Secretary Sutters. In addition to the partnership that I think is strong with the Health Policy Commission, our partnership with the Executive Office of Health and Human Services across a number of fronts, particularly over the last couple of years, is really, really critical, I think, to doing the work that we need to do in government. So I thank you for that. To David Seltz and Ray Campbell, the entire staff at HPC, thank you for all that you do, and to the good folks at CHIA as well. And of course, to my team, your team in the Attorney General's office, Eric Gold, Sandra Walitsky, who celebrated a birthday yesterday. I'm sure this is exactly, I don't know what you were doing yesterday, but you weren't having cake, I know, and anticipating today's testimony. And Amara Azubike, who will be presenting to all of us in just a few minutes. Look, I just wanted to share a couple of thoughts this morning. I know, and you know, that when it comes to ensuring health care as a right and not a privilege, Massachusetts really stands alone. And over the past few years, it's been my honor to stand with you against efforts to dismantle the Affordable Care Act, efforts that would jeopardize so much of the progress that we have made here in Massachusetts. Last year, we sued to protect cost-sharing reduction payments that allow tens of thousands of Massachusetts residents to access care on the Health Connector. We've also led the charge nationally to protect against cut-rate, low-quality insurance products that could destabilize our health insurance market and put families at risk at the very moment they need care the most. And just last month, an attorney from our office was in Texas defending the constitutionality of the ACA. I also appreciate the partners in the room who worked hard to ensure that we had legislation that Governor Baker signed ensuring women's access to reproductive health care in the state. All of this is critically important. We know we need to stay in this fight. We will stay in this fight. We know how high the stakes are, not just for the 20 million people around this country, but hundreds of thousands here in Massachusetts. We got to continue to do the work. So know that that is my commitment and our office's commitment. We're also committing, though, to offense, and it's not just about holding the line and defending the progress that we've collectively made as a state. It's about building on that record, building on that progress. Massachusetts, now more than ever, must continue to lead this country when it comes to health care. And that starts, of course, by addressing cost and distribution challenges that make our system, as great as it is, unfair and inefficient in many ways. And fundamentally, as it's always been for me, cost and distribution challenges really are about access. And fundamentally, that's what I care about, what you care about. We know that some of our poorest residents will still spend a third of their yearly income on healthcare costs. We need to do better. We know the work we have to do on social determinants, and I think a lot of progress has been made in terms of the learning and the thinking in this space. Still, 75 cents of every healthcare dollar is spent on managing chronic conditions. The biggest drivers, of course, remain the social determinants of access to food, stable housing, exercise, employment, and prevention education. And by focusing on these social determinants, investing in people before they get sick or before they need care is one of the best ways to reduce health disparities and to lower costs. And so earlier this year, with the help of so many in this room, our office updated our community benefits guidelines, and I want to take a moment once again to thank everyone who participated in that process, who lent our office their expertise and advice by serving on our task force, from community hospital leadership to providers and medical experts. These new guidelines will help direct more than $300 million each year into local programs to improve community health, and we're committed to expanding on that work. Last week, my office was proud to announce a $1 million grant from the U.S. Department of Justice to partner with Sandy Hook Promise, which is an organization founded and led by several families who lost loved ones during the terrible shooting in Newtown, Connecticut. With this funding, we will be able to expand and supplement school-based violence prevention and mental health training to nearly 140,000 students across Massachusetts. So we're pleased about that. And of course, to truly lead on healthcare, we must continue our work to end the opioid crisis that continues to take lives every day here in Massachusetts. Combating the epidemic has been and remains my top priority. We've worked hard to change laws to make fentanyl trafficking a felony. We've worked with the medical community to stop unsafe and illegal prescribing. This summer, as part of our multi-state investigation that Massachusetts is helping to lead into opioid manufacturers and distributors, we sued Purdue Pharma, the makers of OxyContin, and its owners and executives. Purdue made hundreds of millions of dollars in Massachusetts alone, based on the evidence that we've discovered to date, off of what we believe is deception and addiction. The more drugs they sold, of course, the more money they made, and the more people here in Massachusetts suffered and died, and we intend to do our job as a matter of law enforcement and bring accountability to this space. At the same time, though, we know that while these efforts are critical, they're not enough, and we need to stop abuse before it sets in. That's why I'm heavily focused on prevention and prevention education. These days, when I talk to parents about keeping young people healthy, I'm hearing increasingly concerns about vaping and juuling more than anything else. I think over half of our high school students in Massachusetts have reported trying these products. Half, that's amazing. When you think about all the efforts made over the years to stop teenage smoking, and here we are again with what our office believes is in many ways a playbook ripped out of the pages of Big Tobacco years ago. So earlier this year, my office announced that we were opening an investigation into Juul Labs specifically, to see if the company intentionally created a market for young people. We've also taken action against online retailers, and we're looking at brick and mortar operations. But I just raise this as an issue because as I've done roundtables with kids in middle schools around the state, this is the issue I'm hearing more and more about, and I know it really presents significant concerns. When it comes to opioids, however, my office has continued and expanded our work in partnership with the GE Foundation, Chris Herron, and Health Resources in Action on the $2 million program we call Project Here. We've also updated that to include the issue of vaping and juuling. I want us to be current in meeting kids where they are and speaking to issues that they are presented with in real time. We recently released another $450,000 to schools and nonprofit organizations in 38 cities and towns as part of this effort. And now, as a result, this comprehensive substance use prevention education is available to every public middle school in our state. And so we're going to continue to focus and support efforts to provide that kind of education. Guaranteeing access to substance use education, investing in social determinants, modernizing community benefits, and defending the ACA. These efforts are only possible because of the deep commitment to access and healthcare innovation shared by the people in this room. It's that same spirit of collaboration and willingness to challenge ourselves that brings us together each year to discuss cost trends and market challenges. I enjoyed listening to the end of the last presentation on what is certainly an important topic. Today, my office is excited to build on that partnership, and in that spirit of teeing up challenges, we wanted to present our findings for this year's Cost Trends Report. Well, total healthcare expenditures in Massachusetts grew only 1.6% last year, well below the cost growth benchmark. Enrollment in high deductible plans is increasing. The onus is increasingly on consumers to control their own healthcare costs. That means that everyone needs to have access to accurate and timely information about cost and quality. But our report found that getting information about the price of healthcare services is often nearly impossible. thanks to the complexity of the underlying payment arrangements. A service that costs $1,000 at one hospital might only cost $300 at another hospital. A hospital with a reputation for low costs might still be relatively expensive for an MRI or radiology or other service, with no simple way for the consumer to know in advance. Our report also discusses the costs associated with administrative complexity, something that Dr. Jha highlighted in his presentation yesterday. For example, one study found that in medical offices, for every 10 doctors, there are 7 employees engaged in billing activities. Today, the team from my office will present the report and our findings in greater detail and lay out our argument for reducing administrative and financial complexity and increasing transparency. On this and on all other issues I've touched on today, we look forward truly to continuing our partnerships and our collaboration with this commission. At a time of uncertainty, it's imperative that we continue to find ways to collaborate, to innovate, and to plan for the future. And I know that that is the spirit and the intent of these discussions and of this commission and of the work. I also know that we can only get to truly accessible and affordable health care, the kind of health care that our state, our businesses, our hospitals, our residents, most of all, deserve, by working together and by not being afraid to talk about challenges. So thank you for the work that you do. I now ask the team from the Attorney General's office to come forward and ask them questions. But I'm happy to but I'm happy to take any questions, of course.
Oh, thank you so
on
much.
any topic.
I tell you what, we're afraid to ask questions of the Attorney General. So we're going to turn it over to your staff, which we can't.
Some are not.
We have too much respect for you, too.
No,
So thank you so much again for taking the time. And again, I want to indicate how pleased I am about the level of cooperation between our offices. Thank you so much.
Terrific. Well, it's what Massachusetts deserves. Thank you. Mare?
Okay. So if you'd be nice enough to introduce yourselves, and we've seen you before, and it's always a pleasure to have you back. So, Sandra.
We're happy to be here. I'm Sandra Walitsky. I'm an Assistant Attorney General in the Healthcare Division. Can folks hear me?
Yeah.
And this is my colleague, Amara Azubike. I want to thank all the commissioners and the Health Policy Commission for inviting us to take the time to share some findings from our recent cost trends report. As you know, our office has used our unique subpoena authority to examine market trends and report on our findings since 2010. Our prior reports have documented inefficiencies in the distribution of healthcare dollars, including provider price variation unexplained by differences in complexity or quality. We've documented higher levels of commercial spending on care for residents coming from wealthier areas in the state. This year, we examined payment methods in the commercial market and how they may be driving costs. First, I'll discuss our findings on how healthcare services are paid for in the commercial market. Through a review of contracts between hospitals and payers, we found variation across payers, products, providers, and services in how payment rates are determined. I'll present our findings on both hospital outpatient and inpatient payment methods. Then Amara will present on the implications of these findings. First, she'll discuss the direct impact of this complexity on administrative costs, a cost driver noted throughout the day yesterday and in the commissioner's remarks this morning. She'll conclude with a discussion of how this variation in underlying payment methods makes price comparisons more difficult for market participants. And she'll end with our recommendations. So this slide summarizes our findings on hospital outpatient contracting. As you know, outpatient spending accounts for a high and growing percentage of total healthcare spending. So this is a priority area for cost containment and transparency efforts. And we found significant complexity and variation in how fee-for-service rates are determined across these contracts. As this slide describes, the largest payers in Massachusetts use fee schedules in different ways to pay for outpatient services. A fee schedule is a detailed listing of services and the corresponding list prices that payers have established. The parties then typically negotiate multipliers that are used to inflate those base fees for certain groups of services. So for example, the parties may negotiate a multiplier of, say, 1.2 for a particular set of outpatient services, which would mean that the provider would receive 120% of the payer's base fee schedule for those specified services. We found that 2 of the 3 big payers in Massachusetts negotiate multipliers by categories of outpatient services, but they divide their fee schedule into different groups of related services for purposes of those negotiations. One payer uses 17 groups of related services, the other uses 12. So for instance, Payer 2's hospital contracts include a single multiplier for radiology services, whereas Payer 1 negotiates up to 3 different multipliers for radiology-related services, one for general radiology, one for high-tech radiology, and then another negotiated multiplier for imaging agents. The third payer has a different approach. While its contracts refer to 4 categories of outpatient services, these categories are not the basis of rate negotiations and do not contain associated multipliers in their contracts. Instead, this payer starts with an individualized fee schedule for each hospital and then negotiates an overall rate of increase for that hospital's outpatient services, which is then realized through changes to the hospital-specific fee schedule. We found more variation in that fee schedules also vary significantly by insurance product. There are typically different rates for HMO and PPO products. However, in our examination, we also found that some plans and providers have different rates within their product offerings, up to 4 different HMO rates and 6 different PPO rates. This means that there are different prices within a plan for the exact same services, depending on factors like the member's employer or the provider group affiliation of the member's PCP. And these rate variations within products can be significant. For one payer and one hospital system, we found that PPO prices for the exact same services varied by up to 57% depending on the member's employer. Now, a consequence of this approach to reimbursement is that hospitals negotiate different relative prices, sometimes significant different relative prices for different services. In this slide, we've depicted the outpatient fee schedule multipliers, which translate directly into prices applicable to several kinds of outpatient services for one payer, for one product, at a range of Massachusetts hospitals. For each hospital, we plotted 3 points to represent that hospital's negotiated multipliers for outpatient surgery, laboratory, and high-tech radiology services. Now, the hospitals are organized here by size of the surgery multiplier, represented in blue circles. And this chart shows that other multipliers, laboratory in orange triangles, high-tech radiology in gray squares, don't necessarily align with that surgery ranking. What this chart shows is that a hospital that's a good value for radiology, for example, may not also be a good value for outpatient surgery. Now, we found that some hospitals in our study were very expensive for almost everything, and other hospitals were very low cost for almost everything. However, this was the exception. We found that significant differences in relative payment rates by service existed at most hospitals in our study. Now, this approach to outpatient payment means that you need a lot of information to make an effective price comparison. A hospital with a reputation for being low cost may indeed be low cost for many or almost all services, but maybe not for the service that you need. Now, not all outpatient services are paid based on a fee schedule. Where the payment methods deviate from fee schedules, we found they were even more difficult to compare. You can see in this slide a case study we did of contractual payment terms related to observation services. Now, observation services are short-term assessments used to determine whether a patient needs to be admitted for inpatient care. And we found significant variation across the big three Massachusetts payers in the way this service is paid for. So for example, payer 1 reimburses for observation services based on defined time increments, but breaks out those time increments in different ways, in actually 6 different ways across their contracts with hospitals. Another payer uses a base rate for each hour of observation with a negotiated multiplier multiplied by the number of hours of the stay. The third payer just uses an all-inclusive 24-hour per diem rate. And each of these rates further varies by insurance product. It's hard to compare these approaches and determine which one will provide the best value for consumers. And in some cases, it's impossible to tell because one option will be cheaper for a short observation stay, but much more expensive for a longer stay. So what this means is that consumers getting the same service at the same hospital may get very different bills due to differences in the underlying payment methods that's been negotiated between the hospital and their payer. These differences in methodology, however, are not transparent to purchasers. On the inpatient side, payment methods are somewhat more standardized across the big three payers, but variation does exist across the Commonwealth. So this slide shows the percentage of Massachusetts hospitals with which each carrier uses a particular inpatient payment method, totaling over 100%, where multiple methods are used by a single payer for some hospitals. So the big three payers, represented on the left, predominantly use diagnosis-related groups, or DRGs, for inpatient payment, and that's reflected in the tall blue bars associated with payers 1, 2, and 3. But while these three payers primarily use DRGs, they group diagnoses differently, use different versions of DRG groupers, and apply different severity weights to those groupings. Outside of the big three payers, we found that other payers use a range of different inpatient payment methods, including percent of charges or a just negotiated discount off of the hospital's list prices, shown here in red, and per diems, or a negotiated fee for each day of a hospital admission, shown in green. So for example, in this chart, you can see for payer 4, over 90% of its hospital's contracts include a percent of charges payment for at least some services. Finally, across inpatient and outpatient services, we found that billing requirements vary significantly across payers and providers. Coding and authorization requirements, as well as documentation requirements for determinations of medical necessity, vary significantly across commercial plans and sometimes across products within a plan. And Amara will present on the implications of these findings.
Thank you. Thank you, Sandy. So why does this matter? First, I'll discuss the impact of this complexity on administrative costs. Then I will discuss how this complexity makes price comparisons more difficult. This complexity matters because administering a complicated set of healthcare payment methods is expensive, and there's no clear link to added value for patients. Yesterday, Dr. Jha cited data that underscore our findings. The U.S. is an outlier in healthcare spending, and a major driver of U.S. spending is administrative waste. While there have not been published studies of this cost in Massachusetts, one national study found that 25% of hospital costs are administrative, and another study found that for every 10 medical doctors providing clinical care in a medical group setting, there are 7 full-time employees on the provider side alone engaged in billing activities. One can imagine that more administration could reduce overall costs by increasing efficiency. However, the data suggests the opposite. A study comparing administrative costs of hospitals in 8 nations found that the total hospital costs were highest in the nations that had the highest hospital administrative costs. The varied payment system that we observed in our study also matters because this complexity is a barrier to price transparency. Here again is the chart that shows different negotiated multipliers for different services within a single payer. As Sandy described, this approach to outpatient payment means that different services within a single hospital vary significantly in relative price. For instance, on this chart, Hospital 7 is high-value option for laboratory service for this payer. Its laboratory prices are 47% below average, yet its prices for radiology services are 28% above average. These price differences are significant for consumers, employers, and providers who need to make value assessments when comparing different payer and provider rates for different services. Massachusetts has some important tools like the Relative Price Index that aggregate hospital prices to facilitate high-level price comparisons. This aggregation is valuable for analysis of overall price relativities, but it is not well tailored to capture variation in prices for specific services. So market participants may not be making the most efficient choice if they are relying on aggregate measures or provider reputation when deciding where to get a particular procedure. To be clear, the fact that some hospitals are lower cost overall but have very high rates for a particular service does not mean that price variation and overall payment disparities does not exist. What it means is that purchasers need additional information to make reliable price comparisons for specific services. Service level price variation creates obstacles for consumers who want to shop for high-value providers. One way consumers identify these high-value providers is through tiered insurance products. On this chart, each pair of blue and gray bars represents a hospital's prices for surgical daycare and high-tech radiology for one large Massachusetts payer. The hospitals are organized in the graph based on their copay tiering level, shown in yellow, for both surgical day and radiology services. For example, Hospital 25 on this chart is classified as a Tier 1 hospital with a copay for $150 for surgery, and yet it is significantly more expensive for this service than hospitals 26 through 29, who are classified as Tier 2. Patients who receive surgical care in these Tier 2 hospitals have copays of $250, even while they are receiving less expensive care. This means that consumers are, in some cases, motivated by their tiered network plans to choose care that is actually lower value for that particular service. Wow. Tiered network products are supposed to motivate consumers to choose high-value care by offering lower copays if they choose a provider with the preferred tier classification. However, as this chart demonstrates, we found that tier status is not a robust predictor of actual prices and can actually missignal consumers about the price of the service. And consumers need accurate information about cost and quality to make cost-efficient choices, especially as they are increasingly enrolled in high-deductible products. And while Massachusetts law requires payers to maintain online pricing tools that consumers can use to look up price estimates for specific services, reported consumer use of these tools is limited. Also, these price transparency tools are not available to employers, who pay for the majority of healthcare costs and select the benefit plan design offered to employees, or to referring providers who frame the options available to their patients and should be able to assess the value of specific specialty services. These market participants, referring providers and employers, also need to be able to look across payers to identify high-value services. This chart shows rate multipliers for 2 Massachusetts payers for radiology services across 32 hospitals. Payer 1 is represented by red triangles and Payer 2 by blue circles. From a provider's perspective, this chart illustrates that identifying a low-cost referral for a particular service may not be possible without information about the patient's insurance. For instance, Hospital 11 on this chart is a very low-cost radiology option for Payer 2, but for the same service at the same hospital, it is significantly higher cost for Payer 1. It is important for healthcare providers to know the relative prices of different services at different sites of care for a few reasons. So they can refer patients to high-value specialists to contain overall costs, to perform on-risk contracts, and to guide patients who are increasingly in high-deductible plans to affordable options. For example, a provider who wants to refer a patient to a high-value hospital for a radiology procedure would need to know the patient's insurance carrier, and while this chart only reflects payer rates for one insurance product, A provider would also need information about the patient's insurance product and sometimes even their patient's employer group, as rates vary within payers and across products and employer groups. Similarly, the ability to make service level price comparisons across payers is important for employers who seek to create innovative, high-value plan offerings that account for service-specific rate variations. During panel testimony yesterday, Ms. Leora Stone highlighted for us the real challenge for employers. She noted that it's hard to contain cost when you don't know what's driving them. With timely, accurate pricing data, employers would be able to steer employees to high-value options well before patients have developed relationships with their doctors or in acute healthcare situations. So based on these findings, we offer the following recommendations. First, there should be further study of administrative costs associated with the current approaches to payment methods for healthcare services. One way to start would be to form a working group with representation from market participants that could determine a consistent way to report on these costs with the goal of developing strategies to reduce them. Second, we should reduce complexity and explore increased standardization where appropriate in the methods for determining underlying healthcare payments. And finally, we should establish real-time service-level price transparency for employers, consumers, and providers. A simpler underlying approach to payment methods would allow for new transparency initiatives that would enable purchasers and providers to compare options for specific services. And thank you for your time, and we're happy to answer any questions that you may have.
Well, your ears must have been burning, because the last set of questions that we raised among us is that we need to learn more about administrative costs. Thank you, thank you, thank you. So I have just one question, and I'll turn it over to some. So this is incredible information. Now, do you turn this back to the payers and say, do you know what you're doing? And do they even know? And I don't say that negatively about, they may not know what they're doing relative to another payer. So I'm just
Chairman,
curious.
I think they just did to the payers in front of all of us.
Yeah. So do you talk to them?
Yes. So as part of our examination, we do have the opportunity to sit down with market participants and transcribed interviews to learn kind of from their perspective what's driving the variation that we observe. But I think, Chairman, your question really gets to kind of next steps. Certainly, we see this forum and the opportunity to share this work with all of you and the public as an important launching point for these conversations. And I think as reflected in our recommendations, we raise a lot of questions in this report. And I think
Are we allowed to know which one, who's payer one and who's payer two and who's payer three?
So,
Or could we get it ourselves?
we've published blinded because the point here really is that even across big payers, we've documented this compelling and striking fragmented approach to payment, and determined that it wasn't necessary to make that point, to name names.
Well, thank you. Comments or questions? Would you?
I'm sure Dr. Keller has some, yes. Excellent presentation, thank you so much. If you can flip back to slide 40, which is comparing prices across providers is challenging. What was fascinating to me is going back to several of the conversations we had yesterday about tiered networks. If you look at your tier 2 copays and that second tier network, it would be really interesting over time if we could look at that combination of premium and copay together. This came up several times yesterday from the purchasers. It just is surprising to me to look at this and see that this small group of, I guess it's hospitals, 26 to 30-ish, 29 maybe, would be considered tier 2. And maybe one of the things we need to do is to find a way to creatively change the definition of tiering so that it does include the copay. I don't know how the other commissioners thought about this, but that was really interesting to me. And Chris may go back to your question yesterday of how do we go either to more limited networks, or if those are not palatable to employers and purchasers, then do we need to completely creatively and innovatively rethink how we tier the different providers?
Yeah, thank you for that comment and suggestion. I think it harkens back to work that we shared with the Commission a couple of years ago in our own thinking about what innovative approaches to tiering might look like, which I think is supported by the data that we've unearthed in this examination, which is that, you know, in the point of service tiering has some challenges embedded in it, right? One of which is this rate variation that we've documented here, but there are other challenges as well, like the stress of having to make those shopping decisions when you're sick and you've already developed relationships with a referring provider. So I think this slide and your comment speaks to the need for innovative approaches to tiering, potentially to include consideration of tiering at the point of enrollment, you know, and thinking about ways to adjust not just copays, but also premium contributions to reflect an upstream decision of a consumer to opt in to a higher value system of care.
I think this presentation is terrible because of what it does to my blood pressure, which after the readmissions discussion didn't need to go up any further, but seems to be going up.
Much less after the cost of what that blood pressure medication is going to be.
This is degenerating, and it's really not my fault. I want to know, I guess, a little bit about the extent. Did you find out from any of the providers about what had been happening to their administrative costs? I know you cite the national data. Did you do any surveying about what their own internal spending has been on administrative adherence, or do you have any anecdotes or anything like that would help us?
Unfortunately, that was not within the scope of our examination. I think it certainly begs the question and is a direction for further study. But you know, the national data was the best that we could find to speak to the provider's experience of this complexity.
And I just want to highlight one other issue that I think you mentioned in passing, which I suspect is important, that the severity adjustments that they're doing all differ across the payers. And so the severity adjustments are things like if the patient has high blood pressure, which I don't see how one could not, after this, and then visits the physician, that gets recorded on the code, and then the patient is more severely ill, and so then you sort of get paid more for them. So that they both have to invest an enormous amount of time and resources in figuring out everyone's blood pressure. But then it also counts differently, so they may have to measure it differently for different payers and different plans within payer. Is that, so did I correctly hear you about all of that?
Yeah, I mean, we didn't make specific findings on the severity adjustment and the way that those are coded, but that's certainly consistent with what we've observed kind of overall about the ways that coding and billing requirements vary across these plans and also within plans, which was something that we were really surprised by as we dug in deeper to these kind of administrative areas of inconsistency and variation.
So I'm going to take one more question, but I want a commitment from you that you'll come back and talk with us some more about this, because this is going to be a high priority for the commission. So
Yeah, just a quick suggestion. If you go all the way to the other side of the payment system, so all the way from fixed prices for procedures and all the multipliers and all the adjustments and all the work that goes into claims-based, there are examples of direct contracting that are, so there's a reason restaurants go away from, detailed menus and go to go to buffets, right? So direct primary care is occurring in this state in a small degree. I know Iora Health has gotten a lot of press. They don't bill, they don't have claims base. They devote all of their resources to patient care after negotiating a fee for everything. So as you continue your investigations, I hope you look at some of these direct primary care models. There are also examples of employer direct contracting with providers that are disintermediating the insurers. And there is an ultimately simple way. It's really hard to get there because of the spaghetti that exists and that you've helped us begin to unravel. We all know now why we get those things that say this is not a bill, right? Because it would take 30 pages to explain it. Thank you very much.
Well, again, I want to thank, this was great stuff, and we will be back to you. Thank you so much. All right, so you've been all very patient, so we need to take a break, and I know breaks take longer than they should. Not that they should, but they do. But let's try to be back in 10 minutes because we need to keep going. So thank you so much. Colleen, I don't know who did the time. Please. Thank you.
Thank you. Excellent job.
How are you?
All right. I know there's a lot to talk about, but we also have some really good panels.
No idea how many calories. 80. Who cares?
I'm Rochelle. Nice to meet you.
Hello. All right, so let's,
We're going to start. Please sit down.
okay, please.
Oh, okay.
All right.
All right, so for our first witness panel of the day, we're going to focus on the issue of that Trish laid out so nicely for us at the beginning of the day, returning to this issue of pharmaceutical spending prices, and with a real focus on some solutions that Massachusetts should consider moving forward. I do want to say at the outset, I was particularly encouraged by the comments yesterday from the governor and the speaker in terms of their commitment to return to healthcare and some potential healthcare legislation in the next session. And did want to note that last year, or this year, earlier this session, both the House and the Senate did include a number of provisions within their bill on pharmaceutical transparency and pharmacy benefit manager transparency, academic detailing. And while that ultimately that comprehensive omnibus bill did not move forward, I would note that there was, I think, more consensus than disagreement among the branches on those pharmacy solutions, and would also note a tremendous stakeholder engagement and collaboration with the industry and with advocates, a number of the people on this panel in crafting those. So this discussion is very timely in that the legislature is, of course, and the administration thinking about new solutions in the new year, and so hope to really be able to bring forward some of those great ideas with this tremendous panel. I will not belabor my introductory slides other than to say pharmaceutical spending continues to be a driver of healthcare. We know that. Here on this next slide, I will not even attempt to walk through this particular slide, but the point here is that it is a very complex supply chain, sales chain. And if you can just kind of think about the red arrows here, these are contract relationships. The blue arrows are product movement, and the green arrows are financial flows. This is an incredibly complex industry and financing and contracting, and so really great to have a great panel to help us be able to break this down and think about different solutions at different points of the supply and sales chain. This is just something that we got out of pre-file testimony specifically around contracted pharmacy benefit managers in Massachusetts. Most of the major health plans in Massachusetts do contract with the PBM, but as you can see here, most of the health plans contract with different PBMs, and what they contract with the PBMs to do also varies dramatically by the different payer, again, adding to some of the complexity in this system. Finally, would just note from our pre-file testimony, this was the #1 concern of health plans that they identified in the state's ability to continue to meet the healthcare cost growth benchmark, and had a particular emphasis on high prices for new specialty drugs and price increases on existing drugs. So with that, I'm going to turn it over to Commissioner Kreider to help moderate this particular panel.
Thanks, David, and thanks in advance, panel, for respecting that we have a time problem and a lunch need. We have Sarah Edmond from ICER, Rochelle Henderson from Express Scripts, Amy Rosenthal from Healthcare for All, Daniel Tsai from the Executive Office of HHS here, and Leslie Wood, State Policy for Pharma, trade organization. So I'll give you each 3 minutes, I think you've been told that in advance, to introduce yourselves and explain your positions, and then we'll get to quick Q&A, and we'll break for lunch. Try to break for lunch on time at 12:15.
Thank you, Commissioner Kreider. Thank you to all of the commissioners for the opportunity to be here today. I'm Sarah Emond from the Institute for Clinical and Economic Review based here in Boston. As you've heard throughout the morning, the steady rise in spending on prescription drugs is hurting patients and their families, straining state budgets, hampering the growth of businesses large and small, and eating into the resources we have available for meeting other social goals. What I want to focus on today in my remarks are the possible solutions, with a specific focus on how research from ICER can support the state's efforts to move from volume to value in pharmaceutical spending. First, a bit about ICER. We're an independent nonprofit research institute that produces reports analyzing the evidence on the effectiveness and value of drugs and other medical services, a process marked by extensive input from all stakeholders and public hearings. ICER's mission is simple: sustainable access to high-value care for all patients. Our work is distinctive not only for the public and transparent manner which we do our work, but also because we produce a value-based price benchmark for the therapies we review. A price that rewards true innovation by aligning the price with the long-term value the drugs bring to patients. The existence of this other price lets us know when we might be getting ripped off and when we're not. Its existence, it also lends itself to several potential policy solutions. Negotiating supplemental rebates in Medicaid. Enabled by state legislation, New York's Department of Health took action this year to demand larger supplemental rebates from manufacturers if a drug threatened the Medicaid program's new cap on drug spending. New York was able to confidentially and effectively negotiate additional rebates on nearly every targeted drug, creating significant savings for the program. In the one instance, when a manufacturer would not voluntarily provide that financial relief, New York Medicaid used ICER's value-based price to determine an appropriate rebate to seek from the drug company. Massachusetts Medicaid could pursue a similar strategy and use our independent assessments of value as the anchor for supplemental rebate negotiations. 2, allowing the Health Policy Commission to require information from manufacturers when launch prices exceed the value-based price benchmark. Similar to the authority the HPC has now to compel other parts of the healthcare system to account for their contributions to increased spending, a manufacturer that launches a drug with a price far above the ICER value-based price could be required to provide evidence on what factors led the manufacturer to choose its price. 3, moving to a value-based formulary. For employers and purchasers like the GIC, who are seeing pharmaceuticals consume a larger and larger share of overall healthcare spending, ICER's work can inform a pay-up-to approach. The general principle is that ICER's value-based prices could set the ceiling reimbursement a payer would agree to for drugs, while giving access to all drugs through the formulary. This approach ensures that all pharmaceutical spending is based on value and not based on volume or rebates. 4, informing manufacturer choice of price and thus facilitating the grand bargain. This requires no state action. However, we are encouraged that some innovators are looking to ICER's research to choose a price and in exchange are pushing payers to offer streamlined access to the drugs for their patients, the so-called grand bargain. We saw this from Regeneron and Sanofi with their PCSK9 high cholesterol drug, and in return, Express Scripts made it administratively easier for physicians to prescribe the drug and more affordable for patients to access the drug. At the end of the day, we must remember that patients and families are the ones losing when we allow prices out of line with value. Patients like Ray. Ray recently saw a drug approved for his rare disease, available for $450,000 a year. Even with insurance, he was facing unmanageable expense, so he was deciding whether to take the drug or enter palliative care to preserve some financial resources for his family after he was gone. This is not a decision any of us would ever want to have to make, and yet families in this country are making it every day. We can do better. We can have amazing innovation that improves the lives of patients like Ray without bankrupting families, employers, and states. We must do better, and we at ICER are at your service to help.
Thank you very much, Sarah. Rochelle?
Good morning, and thank you for the opportunity, Commission, to come here and speak with you about the strategies adopted by the states and opportunities and the challenges that face us in the future as it relates to prescription drug policy. So as the Vice President of Clinical Research at Express Scripts, I have three primary functions. The first is the creation of the Drug Trend Report, which I'm sure you all have next to your bed and you read and refer to nightly, right? In terms of that. And so that is examining the cost and utilization trends within different therapeutic classes on an annual basis. The second function of and over responsibility of mine is to oversee the product evaluations within our organization. So when Express Scripts comes to market with a solution to impact patients in terms of, for example, things like medication adherence, getting the medication in the hands of the patients and instilling that they adhere to their medications and are compliant with taking their medications. And so evaluating those products and solutions relative to control groups and so on. I won't bore you with the stats from behind the scenes on that. The third thing is overseeing the collaboration activities. So we are engaged with collaborative efforts with various academic institutions to explore different phenomena in the area of pharmacy and activities within pharmaceutical space. One of them, actually, one of our collaborations is with a university you might be familiar with in the state of Mass, starts with an H, ends with a D, related to that. But thank you very much for the opportunity to speak here today. What I want to talk about is we're facing with, without a doubt, the newer innovative medications coming to market are transforming lives. We have newer medications in the area of hepatitis C, which is available to cure, in some extent, 94 to 96% of those suffering from hepatitis C. Newer medications that are made available, innovative therapies that allow children who have suffered from blindness to now be able to see. However, as many of you indicated or are familiar with and the previous presenters, there is struggles or challenges with affording this. So you think about being able to pay for the newer medications that are often specialty and often very expensive, but also being able to sustain the pharmacy benefit in the areas of more traditional medications. So being able to afford the newer innovative technologies that are coming to market with also being able to sustain treatment for patients with diabetes, hypertension, and high cholesterol. Express Scripts has been championing for better for more than 20 years. In order to achieve low trends for our clients, getting medications into the hands of patients and preserving the pharmacy benefit, Express Scripts has repeatedly been a leader in taking bold actions to reduce waste out of the system and being champions for what is possible. Over my 20 years with the organization, we have made a series of solutions available. In light of the rising drug prices, Express Scripts has been able to assist their clients in achieving PMPY, gross cost net of rebates, trend of 1.5%. That was 2017 compared to 2016. As of year to date in 2018, the trend is only 0.6% for the commercially insured population. So I think it was Mr. Cutler asked earlier, what is the ideal rate of trend? I'm not much like Ms. Reilly in terms of forecasting, not going to do that necessarily, but what we're seeing for our commercially insured population is this year's trend is 0.6%. And how do we achieve that? And that's part of the discussion here today. Part of that is there's no silver bullet, right, in terms of the solutions and how do we tackle this. Express Scripts is through innovative solutions, leveraging data, leveraging clinical expertise, impacting and lowering and keeping that trend. Some of the programs that we have innovated in, to which my colleague at ICER indicated, but around our Safeguard RX programs, where we're leveraging the markets, we're leveraging the care and information available to move that needle or to bend that curve, as someone mentioned earlier. In addition to our Safeguard program, we have continued success for our clients in the area of formulary management. We have 25 million members on our national preferred formulary, which has resulted in $10.6 billion in savings.
So in conclusion, I don't
Sorry,
mean to be, the point was opening statements.
Yes.
Because we'd like an opportunity to ask questions.
Great.
So
Sorry,
I don't
thank
mean
you.
Thank you. Good afternoon, Chairman Altman, Vice Chair Everett, and the members of the board. Thank you very much for having me. I'm Amy Rosenthal. I'm the Executive Director of Healthcare for All. And Healthcare for All advocates for health justice in Massachusetts by working to promote health equity and ensure coverage and access for all. We know that prescription drugs are critical to curing disease and maintaining one's health. Amazing new cures, many developed here in Massachusetts, have brought hope and improved health to individuals and families across our state. But drugs don't work if people can't afford them. I think we all know the data, but at Healthcare for All, what really drives us are the individual stories. Each year, we take 20,000 calls on our helpline, and we hear time and time again about the skimping prescribed medicines because they're unaffordable. One call just came in this week of a woman who has diabetes and needs regular medication. She had been on Masshealth Standard. When she got her new job and her income went up, she moved to Connector Care, but now she could no longer afford her copays and needed help. We also recently just got a call from a woman who literally started crying on the phone with our helpline counselor because she was so happy to find out that she qualified for Masshealth. She hadn't been taking a prescription she needed for a while because it cost $90 a month. And the problems are not spread evenly. People of color, immigrants, and those with low incomes suffer disproportionately. And for these reasons, we believe that prescription drugs need to be a top priority. I just want to touch on a few of the things we're thinking about that we heard about from Trish Reilly earlier this morning. First, as it relates to Masshealth. We are going to hear more in a minute, but we know that the drug price spending in Masshealth has doubled over the past 5 years. And as Masshealth pays more and more for prescriptions, there's less available to do other things. So we believe we can reduce drug spending by increasing the state's negotiating leverage, but still protecting consumers. As Sarah talked about, we've been thinking a lot about the New Jersey model, where the Medicaid agency demands supplemental rebates for drugs that are deemed overpriced by a review board. Manufacturers who do not meet these targets have to justify their prices. In the past year, the Baker administration has advanced proposals similar to this one, and Healthcare for All has been having very productive conversations with Dan and others about this, and we're eager to continue those conversations. I also want to talk about the need for more transparency in drug pricing. As we heard from Trish, 7 states have already passed transparency laws that require manufacturers to report on the factors that lead to price increases. Last year, versions of transparency legislation were included in both the House and the Senate bills. And as we heard from Speaker DeLeo yesterday, many of us were deeply disappointed that the legislature was not able to move the healthcare bill at the end of the session. And we urge all parties in Massachusetts to prioritize drug transparency legislation early in the upcoming session. We know this is a critical first step. We also are thinking about laws addressing Pbms that we know 26 states have enacted laws of that nature, and we think Massachusetts also should be looking at ways to protect consumers, thinking about licensure, oversight, rebate transparency, and the like. The proposals I discussed here are the ones that we're thinking most about. However, we continue to have conversations with our colleagues in other states who are also thinking about additional steps. So we just spent time with our colleagues in Maryland who are exploring proposals to create an independent.
Amy?
Yep.
Thank you.
Thank you. That was my last sentence.
I've been informed by the secretary that we are not going to break for lunch at 12:15. So go ahead, Daniel.
Good morning.
Good afternoon.
Good afternoon. Oh, it's 11:38.
All right, fine.
Morning still.
It just feels like afternoon.
Good morning. Clearly, this is a simple topic. We'll have a lot of alignment. So I have 3 slides. I will be brief. First, Masshealth pharmacy spending. It's grown $900 million over the past 5 years. It's significant. As Amy mentioned, that makes it challenging for all the other parts of the safety net that are very, very important to sustain. You'll also see for effect there, that dotted line is the current HPC benchmark. Pharmacy trend is the single largest per member per month cost driver in the Medicaid program. I believe that is similar for commercial payers as well. Slide 1. Slide 2. We have used every possible lever that we have within our current authority over the past 4-ish years to negotiate pricing and more effective rebates for pharmacy. If you look at where our rebate level was in 2014, that was at 34% in the Medicaid program. We were getting around $460 million of rebates. Over the past 3.5 years, we brought that number up to 51%. We're currently at about $960 million of rebates, a good portion of which we do have to give back to the federal government. But that big increase has been the focus of pretty intensive efforts nonstop over the past 3.5 years negotiating rebates, supplemental rebate agreements, establishing a preferred drug list from which to negotiate formularies, leveraging the state's purchasing power. So some of those negotiations we do across all Masshealth lives, regardless of which health plan, PBM, or other structure exists. Those initiatives have proven very, very helpful. Would say those numbers, as the rebates have gone up, are primarily in areas, drug categories where there is competition, and we have been able to drive some sort of competitive rebate negotiation, which brings me to my third slide. The positive effect of competition, hepatitis C. Everyone has talked about hepatitis C drugs. We were one of the first states in 2015, we as administration expanded access for all individuals in the Medicaid program to receive access to these curative therapies regardless of how advanced their disease was. And part of how we did that was we said we wanted to do that. We saw competitors coming onto the market for the first time, and we entered a set of very aggressive negotiations to pick a preferred drug around that. That led to, you'll see what this chart shows that, I'm colorblind, so that the downward sloping curve.
It's red.
Red. It's the net cost that we have blended across individuals on Masshealth with hepatitis C. That is a straight downward looking trend. Every time a new drug has come out, we have opened up negotiations again to ratchet up what the rebates are. The other line going up is the number of utilizers, the number of people each year we have been able to serve with hep C therapies. That's basically been a straight upward line. It has been what we've been able to do with actual competition to negotiate rebates.
So that's such a good slide. I think we should say thank you and pass the baton.
That's a good point.
Thank you. Good morning, everyone. As you know, over the past 25 years, we've seen significant advances in our industry, the biopharmaceutical industry. We've seen, can you not hear? I'm sorry.
Get closer.
All right. So you've seen diseases that have had death sentences like HIV and AIDS go to more of a chronic disease. We've also seen the discovery of a new cervical vaccine, fibromyalgia treatment for the first time, lupus treatment for the first time in 50 years, and the cures that my colleagues have talked about this morning, and hepatitis C that the industry is very proud of. To achieve these advances,
A little louder, Leslie. I
I'm
think.
so sorry. To achieve these advances, we have spent over $90 billion in 2016. And out of venture capital, 30% of all venture capital goes pretty much right across the bridge to Cambridge. And we enjoy our partnerships. We have more than 300 different companies over there. We also employ about 56,000 residents in Massachusetts, as well as supporting 250,000 other jobs. We know that the current health system is not sustainable, and we really do encourage a holistic approach. And we've been working with the legislature on that, as well as various agencies that are represented here today. But we believe that any approach to changing healthcare should have 4 principles in mind. One, and you might be surprised to hear me say this, but more transparency. Patients need to know about the cost of the medicine, what their out-of-pocket is, and how they can access their medicine. And we did announce on Monday new ways that our companies are going to be providing transparency to patients. Also, fairness. Last year alone, biopharmaceutical companies rebated $150 billion in rebates to the supply chain. I think David really did pull a good chart on that. It's very, very, very complex. And we would love to supply more information about that because it is very hard to understand, but it's very important to know where the dollars are going. And we want to make sure that patients are benefiting from that because we don't think they are right now, and that's really not fair. Second, affordability. As part of our announcement on Monday, we are going to make more information about our patient assistance programs available, as well as health benefit information to patients through a new platform that we're launching at the beginning of next year. And then the last one is safety. We did talk a little bit, I heard Ms. Reilly talk a little bit about safety. We really want to make sure that Massachusetts patients know how to safely take their medicines, that they're getting them from a safe source, that prescribers know the correct prescribing information about prescription medicines. We really would like to continue our partnership with the Commonwealth. We really do admire all the work that's been done here, how you have gone above and beyond what other states are doing, and we look forward to continue to work with you.
Thank you, Leslie. So I know there's some sense of urgency for questions here, but I'll take the prerogative with the first one or two. I think it's fair to say that a few years ago, not too many people in the room could spell PBM. It was, kind of lurking in the background. Just a question for Rochelle: why do you think PBMs are under fire now? And maybe Leslie would ask you to comment as well.
Thank you. I think, as the slide indicates, the system is complex. I think folks may not necessarily understand all the levers that the PBM is engaged in. I have the opportunity, and I take this opportunity to extend an invitation. If you happen to get to St. Louis, I'd love to be your host and come see how we are practicing pharmacy differently and applying all the levers. At our lab and facility in St. Louis, we apply data science to create predictive scores, to identify patients that are likely to not engage in prescription adherence to medications, for example. We couple that with innovative technologies and solutions, so things that are occurring in Silicon Valley, things that are occurring in the Vortex, for example, in St. Louis, innovative solutions and technologies coupled with our clinical specialization, and bringing those three things together to impact not only lowering trend and impacting cost.
So I understand.
Yep.
I mean, there's a lot of good,
Yes.
right? And
Yeah.
there's a lot of innovation. There's a lot of jobs.
Yep.
There's a lot of value to so many of these drugs, but now PBMs are under fire. What is it about right now that is different than 5 years ago for your industry?
That's a really good question, and it concerns me on a daily basis, trying to understand, because I understand and get to see the wonderful things that we do and how we're affecting those things, and sort of wondering, waking up, why is it now and what is it that's going on? So maybe I can defer too, because I'm still perplexed as well.
Leslie, any thoughts?
I think that we're starting to see the misaligned incentives. I think there's been a lot of pressure on pharmaceutical companies to raise that list price to increase the rebates that are seen throughout the system. And there's a lot of unknowns about where is that money going to. There's so many different relationships. For example, a health plan might get most of its rebates, or they might decide to take less rebates but to get a known amount. We just don't know all of the different relationships, and I think, as David's slide showed, there are so many different ways out there. That's why we have said we want to move to value. We want to take away this incentive for higher list prices. We want it to go to the patients, and our companies are committed to being undervalued.
So we'll come back to value, but a question. Rebates are different than discounts, right? So rebates are tens of billions of dollars in return for services, right? Or programs that the PBM provides. Is that right? How would you describe the value for the rebate? How do you define that? How do you put a price on a program or whatever you get in order to generate the rebate?
Sure. So the discounts and the value and rebates are, I would say, different in terms of what they do. The rebates can be rebates on negotiated, and I can defer to my former colleague on the rebates are clearly defining that, but it is different than discounts. So Express Scripts passes through. So to your point about sharing, passes through more than 90% of the rebates that are extracted onto our clients, and to your point about the different the different components and how rebates are transferred and the complexity associated with that. Recently, in terms of thinking about and pulling the different levers and exploring what's possible in the case of a hepatitis C medication, hepatitis C manufacturer, because some of our clients would like to see the rebates and utilize those rebates to be able to lower their the premiums for their clients and premiums for their beneficiaries in essence. So to be able to lower that, they utilize the rebate dollars. So within hepatitis C, there's a manufacturer that's created an alternative NDC. So the client can determine if they want to utilize the NDC with the rebate or utilize the NDC without the rebate and have a lower net cost.
So suffice to say that transparency is made difficult by complexity, and to the extent that you can simplify the elements that go into the rebate program that create costs for some of the purchasers sitting at the table, I think would be useful. I'm going to ask Secretary Sutters to jump in.
So
maybe this is just too simplistic. If we had fair and adequate and transparent rate setting for pharmacy, why do we need rebates at all?
Yeah.
You don't?
We don't.
As I mentioned, some of the clients in terms
I don't,
oh,
but
sorry.
I'm just if we had, like in every other thing, we had transparent, we understood what went into the costs, it was available for people to understand it, and it was transparent, and it was rate setting, why do you need rebates? Seems to me I'm just being completely, it's smoke and mirrors. And while I appreciate the, whoever did this chart, a more accurate reflection of this chart of this $784.3 million for rebates for the Commonwealth of Massachusetts, 62% of that goes back to the federal government. So that is not an accurate reflection of rebates for the Commonwealth of Massachusetts at all. So Amy, Sarah, you want to take that one? I always like to be a conversation killer, you know?
You're a conversation starter, Secretary Sutters. I think that, so where we come down on this is that the rebate structure was designed to incent formulary placement at its core. And so in order to get tier placement at one and drive higher volume, you'd get a bigger discount, either over time, hitting a utilization point, or upfront. And what that's done is created a perverse incentive in a lot of cases where we're not actually incentivizing patients to have the highest value option first. And we have seen that in our work with plaque psoriasis is probably the best example, but we see it in other cases as well, where the value-based price is actually quite different among the different drugs because they work differently for different patients, and yet everyone, for instance, has to step through Humira because the size of the rebate for Humira.
Yeah, so I think your answer to your question is this whole rebate thing has to be really reviewed. You know, when we talk about the reason why the PBMs are under pressure, it's because of the complexity of what you've created. And this idea of making that was a great statement. Rebates are not discounts. For us poor, what used to be economists, the difference between a rebate and a discount becomes very tricky. So somewhere along the line, we have to really fundamentally look into this whole rebate. You guys claim you're giving all these rebates. People don't see them. They see them in different ways. If you're a poor person that isn't part of the negotiating process, you get none of those rebates. It's like the middle of the summer, somebody raises the price by 20% and then gives you a 15% discount. So, I'm not against PBMs. They provide a valuable service. But if you guys don't figure out a way to do a better job in terms of restructuring this system of pricing, no wonder you're getting pressure. And to the extent that you're not getting the prices we think you're getting, you're not telling the story right. So somewhere along, that's the answer, the reason why they're under so much pressure. We have no idea what's going on. And neither does anybody else. And maybe you do. And maybe it's working, but, I've tried to understand it. And I'm not stupid. And I don't understand it.
David Cutler.
I'm going to change topics away from rebates for a second, but put it in a bigger context. So we have, for hospitals and physicians in Massachusetts, the growth rate of spending is roughly about 1% a year. And for pharma, the growth rate of spending is orders of magnitudes higher. So what I want to know is, give us as a state a strategy where the growth of pharma, let's just go smaller, where the growth of pharma hits 3.6%. So that's what I want. I don't want to hear a bunch of, we're all about rebates and so on. I want to know, how are we going to get to 3.6%?
Sure, I'll start with that one. We have talked to Gia and Mr. Campbell's staff a little bit, and a few years ago, no one had heard about the rebates. And so I have to say his staff is really trying to kind of make sure that we have an accurate portrayal of what is going on in the supply chain. However, what is happening, though, is we still have a distortion. And nationally, we know that spending was 0.6% last year. And we know that with the rebates and discounts, It's not the 5% growth that we saw this year, even though we've seen the trend continually go down, which was predicted after, the ACA lives being covered in 2014, the new compounds being covered, and less generics coming to market in 2014 than in general. But we are seeing that trend. We're seeing many people reporting last year that the net growth on our products was 2%, and that the spending is 0.6%.
Over the IMS data, they're not the most recent. The IMS data show that national pharmaceutical spending, at least as of a couple of years ago, was about 12%.
In 2014.
And with rebates, it was 8%. So you take the rebates, the rule of thumb I keep in my mind is the rebates cut the growth rate by about a third. Okay, so that seems to be national, and I have no reason to think that Massachusetts would be different. So even if I took Dan's size chart, where the growth is, what is it, 6%, 7%, and that's net of rebates? So how is that number supposed to get to 3.6?
So I think one important point that you're raising is the answer is not the same across all different type of drugs. Where there are drugs where there's competition, and they tend to be drugs that have been out on the market, the rebate model has been working well. We have increased the rebates through those negotiations. The net cost has actually decreased in some cases.
Right. But you gave us an overall number, right?
A $900 million
What is
over
the
5
overall
year.
percent?
Overall percent on a per member per month basis is 13% per member per
13%.
month on a gross basis.
So how do we get that to 3.6? How do we get 13 to 3.6?
And I think so we are looking at, as the Secretary has indicated and others, a package, an updated package of pharmacy reforms that we are doing some work on. We're looking at a range of options, looking at what some other states are doing. It's a multifaceted piece. I think certainly one element of that continues to be levers that we have to directly negotiate rebates with manufacturers, some level of transparency such that when there are instances when it's very difficult to justify the launch price of a drug, there is some place where we can start from a negotiation standpoint. It's looking at what states like New York have done. It's part of the dialogue we've had in the state so far with the legislature. We are taking a look at PBM spread pricing, so not just the rebate topic, which has been our PBM discussion to date. Ohio Medicaid found that PBMs were capturing about 9% of the gross value in spread margin, the difference between what they were getting paid by a payer and how much they were paying the health plan, the pharmacies. There was $224 million of value for Ohio Medicaid sitting in the PBM channel, even separate from rebates. And there's some other levers we'll be looking at that will help us negotiate even more effectively the tools we'll need in instances where we are having trouble negotiating with certain high-cost drug manufacturers. So that's just a preview of some of the things that we're in the midst of thinking about to start to bring that net trend number down.
Professor Cutler, I appreciate the question. Just as a point, right now we're paying fee for service. We're paying based on volume. And when we shift to paying for value, we'll see savings. There was a recent survey conducted by a consultancy that analyzed all of the products that ICER has analyzed, which is about 80 drugs. And if the U.S. had shifted to the value-based price on all of those drugs, the U.S. would have saved $9 billion.
My sense, I'll give one comment and then I'll stop. My sense is that the only and it's like the discussion earlier, the only contracts where the suppliers, where the pharmaceutical companies have been willing to enter those contracts are contracts where they know they'll get paid more. And that contracts where they're not sure they'll get paid more, they don't enter into them.
So you're probably referring to outcomes-based contracts, which I actually do not think are the solution to this problem. I think there's only a small subset of drugs for which that's the case. This would be actually setting the price based on an ICER analysis and saying this is how much we're willing to pay for the drug. It wouldn't be an outcomes-based contract.
That is
so
a
it's
different.
different.
That is a different problem.
I would just say that we're not afraid of entering into these contracts. One of our major members is actually funding a lot of the research down in Oklahoma to get the data that was mentioned earlier. And we've offered several times here to bring forth brand managers of concern to talk with the state to help facilitate the conversation.
But I still don't have an answer to how 5% is going to become 3.6.
Right, but it's not 5%, sir.
Well, that's what Ray tells us it was last year. So So Ray says in the Commonwealth it was 5% growth.
But it doesn't take into account the entire supply chain.
4.1 net of rebates. With 5% gross, 4.1 net
4.1
rebates in our estimate.
Okay, so how do I get 4.1 down?
So again, the national numbers are 0.6 from Masshealth is now IQVIA, and their most recent numbers are 0.6%. And we've got 2% in growth, which is under your benchmark amount. And also the 4.1% is as reported by the payers. It doesn't take into account Dr. Henderson's portion of the supply chain.
Okay, Stuart.
Yeah, let me broaden the subject. True value-based pricing should not focus on drugs alone. The fair assessment of this, we ought to be focusing on total patient care. And there are cases in defense of the drug industry where good use of pharmaceuticals really substantially can lower other prices. So ideally, and I'm sure you'd agree with me, David, ideally, we should not be focusing on value of drugs alone, right? And even ICER would, I think, support that. The problem we have is two things. One, we have no, again, going back to my comment before, we just don't know, and not only we don't know, but the people who are running our ACOs and our delivery systems don't know the prices. And I think about Amy's comment, if you happen to be a poor schlep who's not well protected by these discounts and stuff like that, you're winding up paying list price. And so are delivery system people. So the point is that I think you guys have a good case to be made in the broader sense. But in order to make it, we need to sort of bring about this transparency. And it's not only for individuals, it's also for the people that buy the drugs at the delivery system. So again, the complexity of the pricing structure has led to a lot of these problems. Nobody knows what's going on. And probably even you guys don't even know what's going on all the time. So I don't know where to do it, but again, the comment about whether it's the PBMs or the drug companies is that we need to make the system simpler. We need to do what the Secretary and others said. We need to develop a better transparency issue that really explains what the prices are and what the value is. And how we do that, we can use your help.
So let's consider a theoretical possibility that rebates are displaced by a better system, a data-driven system, an outcomes-based system. We've talked a lot about data in the last day and a half. We now have access, capability to get real-time data. Stuart, and for ICER, I think this is relevant. To really understand whether conditions are improving. You take a simple disease like hypertension. There's a lot of people in this room, if we asked to raise their hands, don't know what they paid for the drug. But with telemetry and home monitoring and kiosks and drugstores, we can get blood pressures readily and can compile that data and determine whether or not the drug is generating value. Is it theoretically possible that rebates are going to be replaced by those kinds of outcomes measurements? You mentioned the lab in St. Louis, Rochelle. Is that a way for us to think about moving away from the black box to real hard data and value?
We hope so, sir. One tool.
Still got to get closer.
Sorry about that. One tool that we've heard about, and I believe the Obama administration actually highlighted, there's a clinical decision-making tool called SciAps that's been used in Utah, I believe in Intermountain Care, and they've saved a lot of money providing real-time, looking at, okay, what are my patients, what are their labs look like? How can I pick the right treatment for them based on their labs? And that can lead to better clinical outcomes. What our colleagues at ICER are doing, which we object to, is basically not taking into account a specific patient and their specific criteria, and it's a prospective look. We want to move towards value in a look that's actual patient experience. What is the benefit? Does it benefit that patient? then you get this payment. If it doesn't benefit that patient, let our company take the risk.
So, ICER, you want to respond? Yep.
It's interesting when we hear this criticism of the approach that we take, because right now there is one price set by the manufacturer for the drug at list. And our coverage policies are set up to encourage a population approach to a particular. And so cost effectiveness analysis, which is the basis of ICER's work, also takes a population approach. When the manufacturer produces data to show us when patient subpopulations or particular patients have a different reaction, a different approach, we absolutely include that in our model and produce those analyses. And so when the data are available to do that, that is absolutely part of ICER's approach.
So there may be some common ground here.
No, I mean, I think that, we're interested specifically in talking about value. We know that as data come on the market about patient experience, that things can be improved. We just don't think that we should move drugs into a utility based off a prospective analysis of value. We want value for the patient, and we want individual patient personal preferences and outcomes to be considered.
And just quickly on that, we don't have a system where we can charge patients different prices for how they value it. That's just not the reality of the U.S. healthcare system. If we get to that and we can have personalized payment based on individual preferences, our work would actually support that, but we don't have that system.
I wonder if I could just make one point from the Medicaid standpoint, where there are some slight differences in how we price. The rebate question is important, but we negotiate pricing based on the net cost of the drug, whether it's a rebate, discount, et cetera. And even then, so there's it's clear what our net price is. At the end of the day, though, if there are drug categories that are very high cost, growing fast, and it's hard to know what is the justification for that, if you don't have a willing partner on the other side of the table to be able to negotiate something, you can pretty much figure out the implication of that. That has been the largest portion of the growth of pharmacy within the Medicaid product. So I just want to make sure, even as we discuss rebates and other things, those are all important pieces. What matters to us is what is the net cost of the drug at the end of the day, and can we negotiate to a price that rewards innovation, but is also fair and an effective resource of a steward of public resources.
So, and I wanted to pick up on something that Secretary Sutter said, is all of this is very complicated, and I do worry about our consumers who don't even know how to enter the system or the discussion. And I think that the transparency proposals that we're talking about are very tangible first steps that we can be taking quickly in the upcoming year in order to try to get through all of this and better understand it so that all of the players at the table can really understand. I do also just want to say that last year when I made the transition from working on national health reform to Massachusetts reform, I spent a lot of time talking to business leaders and hospital CEOs and insurers and consumer groups, and this concept of shared responsibility kept coming up over and over again about why things here in Massachusetts work so well. And if I think about the lessons that people were sharing with me around Chapter 58 and 224, there were a lot of people who made a lot of important concessions. Consumers agreed to the individual mandate, which was not something originally that was something they wanted to do. Businesses had an employer mandate, not something they wanted to do, was painful to do. Hospitals and insurers are dealing with cost trends reporting that is not necessarily something people want to do, and those are hard things for each of these industries and groups. And I think that this is one of those times now where we need to look at pharma and understand what is happening, and there needs to be a similar investment here in this state because that's what makes our state successful and helpful and makes sure that consumers are really covered. And so I think big picture, we need to be thinking about that.
I would just one thing you might want to, as you do all the list of concessions, was also 224 also required the Commonwealth of Massachusetts and its Medicaid program to consider APMs and the like. Yes. But I just want to caution, I don't want anyone leaving this room thinking that transparency is what we need to do, because I'm going to go back to a comment that I think Trish Reilly made in her presentation, which is transparency is a piece, but if that is the only piece, then we will really have not done anything in controlling pharmacy. The other point I would make is, and I'm going to go back because I know there's a lot of folks who keep going and pivoting to the Oklahoma model, which is no high-cost drug companies have been willing to come to the table. To me, that is not negotiations. That is not negotiations at all. Sorry, I didn't mean to.
Dr. Henderson had a comment.
Yeah, thank you. To be clear, as contrary to sort of what is being the supposition here is that the PBMs, I'm speaking for Express Scripts in particular, is not necessarily, yes, we love rebates and that's, what we're focused on in terms of keeping and sustaining, right? It is an artifact of, much to the point of which Isa indicated, an artifact of the history of where we are, right? So we're trying various solutions. We have with various clients, depending on if they are benefit and they want to still contain and utilize those rebates to offset, as I mentioned earlier, their premiums for their clients. Option one we are transparent with our clients. That's who we serve in terms of those relationships, in terms of those rebates and everything. So with the transparency, I love your position as that is only one piece related to that. The other is around another solution in terms of adjusting the rebates is around hepatitis C, right? Another potential solution is with the manufacturers and saying, is it for the rebates or not, based on what the client and an option for them to either get away from rebates or stay because they're benefiting. It's part of their system and how they're built in terms of their financial offices. So, thank you.
Other questions?
But as Dan's Hep C drug example, so you can see negotiation when there's competition, we know that the new drugs coming onto the market have no competition. So how is it one negotiates fair and reasonable prices? That's the cost driver. I think it's $600 million. Is that the right number? How close am I?
From a net standpoint, net of rebates, if you look at drugs that have launched after 2014, the majority of which we do not have competition for, the net cost growth, even after accounting for rebates, was $202 million. Put that in perspective on the overall Masshealth program, 1% growth is $160 million. So that's 1.25%. So 1.25% of the entire Masshealth number to get to 3.6 is taken up just by drugs that have launched since 2014, net of rebates, largely without competition.
I have a question. So let's, maybe, I don't know who can, maybe somebody can answer this. So I'm a big ACO, or I'm an ACO in the Medicaid program. And I'm responsible for providing, again, total patient care to a population, try to provide it as high quality and as low a cost. And I'm trying to balance, and I'm the head of it, and I'm trying to balance out all the different components that go into patient care, including, how many surgeries and how much hospitalization and drugs. And I'm dealing with a drug that is the sole drug, so there's no competition here. But I'm not anxious to take on a drug that costs, $1 zillion. And yet I would. So we've had a fair amount of criticism begin to play out among certain cancer delivery systems, claiming that a lot of these cancer drugs, these individual cancer drugs are coming on with huge prices, where in fact they might have some value, but that the prices are so high that they're going to fight against using them unless they really have to do it. So the question is, let's put aside rebates because they tend to focus so much on competitive and formularies, and focus on whether we can reach a stage, whether it's aimed at you, Leslie, and who you represent, where in fact you have some degree of even market forces between the high-priced individual drugs and other forms of delivery. So how does that ACO function in this society? Do they have to turn to a PBM? And does the PBM, then they lose all the leverage. A PBM is not particularly good at that because they're not the ones that are directly doing it. So where does this whole change in the delivery system, and particularly as we put our bets on these ACOs, play out in this market?
I think that's a really interesting question, and I think that's something that we should definitely continue the conversation on. When we talk about our medicines coming on at a high price, there's also the whole continuum, right? For every medicine coming on, we're seeing billions of dollars coming off in the generic market. We have a very limited time to recoup the value of our medicine. I actually had the pleasure yesterday of being in Cambridge with one of our members. It was actually scheduled before we were invited to participate in the panel. And they're actually creating cells that attack disease, where if you have a quarter of a degree change on that drug through the manufacturing process, you mess up the drug. The drug from the cell line, when it goes through the process, it's 6 months for manufacturing to be able to get the outcome. So we understand the tension with price, but our companies put 20% of all dollars in research and development in this country back into the system. So that we understand the tension, we want to be at the table talking about it, and I don't have a solution for you there today, but it is something, we definitely do need to talk about how we can sustain this for patients in the future.
No, I'm not. I'm well aware of how the drug pricing works, and when I come back in the next life, that's going to be my job. I want to be in charge of drug pricing for a big
So let me offer a.
That's not what I'm talking about.
Go ahead.
Yeah.
You got more?
I just want to push her a little more on this issue. That isn't what I'm talking about. I'm talking about drug companies making more money by lowering their prices so that the delivery system can use them in the right way. I'm not talking, and the idea is the current environment doesn't let you do that.
And I think that's what we were talking about, this shift. Like, let's take out this $150 billion in the system, and let's move to a fee-based system. And I don't know how that would work with the ACOs, because some of them are going to be contracting directly with our companies rather than working with the PBM, and that's definitely, I think, a really interesting kind of next steps, David, that we could kind of dig into a little bit more.
So as we're wrapping up here, let's try to move the ball forward a little bit. We're about to have a new insurer, significant new insurance presence in Massachusetts with CVS and Aetna. So this panel hasn't really spent a lot of time looking at Aetna as a payer in Massachusetts because it's been about this big until now. I saw a white paper recently that it's possible that Caremark, and so pretend you're Caremark for a moment, Rochelle, might be promoting the notion of zero copayment for some chronic drugs. Another elephant in the room is that consumers only take their prescriptions about 50 or 60% of the time. So if we're going to reduce hospitalizations for hypertension, obesity, and diabetes, we really need more medical compliance or adherence. So is that a great idea? A good idea? A great idea? Zero copayment for chronic drugs, presuming that maybe patients monitor on a regular basis and there's a reporting mechanism for patients. Could you do that if you were, let me stay with the PBM for a moment. Could you do that if you were Express Scripts? Could you promote that, zero copayment for chronic drugs, as a way to get to Stuart's point about saving costs for the whole system?
To some extent, if it were supplemented with the right support system. So in previous research, we've looked at the relationship of lowering copay to zero in terms of preventative medicines and so on, and you don't necessarily offset the cost, or so it would have to be just lowering the cost in and of itself does not necessarily get you to the positive outcomes that you're looking at in the lower medical cost. If you were to supplement it with both clinical care, additional support, I would be sort of in favor of exploring that, but just lowering the cost to zero for preventative care, we did not, at least in our research, see that that's the silver bullet in terms of getting your objectives.
Okay, last word, Sarah, then we're going to wrap it up.
Just that the move to a system where you're paying a price that's high value would lend itself to a consumer-focused solution with very little to no cost sharing. There's no reason you need to charge a 20% coinsurance on a high-value drug. The coinsurance and copay were meant to incentivize behavior, and if you're getting a good price and it's the right price for that patient, then you could imagine a system with very little cost sharing. That's a vision we should all embrace.
Rochelle.
So absolutely agree, especially as these specialty medications are more and more expensive, right? And if you were to apply a 20% cost share, that's quite prohibitive for most patients, most of us actually, and I'm sure we're all doing pretty well financially. What we've done in the past is an analysis to look at what point is it dissipating in terms of utilization and use of those medications. And what we've identified is that $150 is the tipping point for which patient population will discontinue therapy. So our recommendations to our organizations is that specialty medications and copays be no more than $150 per prescription, because we recognize that most folks are not able to pay for that.
So I think it,
Say no more than $150
Yes.
per prescription?
Per
You obviously don't know what public servants get made.
I just can't believe you said that. Right now.
That's what the analysis showed, to where people will discontinue therapy. Up until that point, we did not see the discontinuation of therapy based on our analysis.
Our helpline fellows did something different. That's
Our consumers.
yeah.
so we'll end with that discordance. But suffice to say, I think what you're hearing is transparency, try to remove some of the complexity to rebates. Innovation is welcome. Thank you very much. We're going to reconvene in 38 minutes. Is that right, David?
38 minutes. 1 o'clock.
38 minutes for another interesting topic.
Bye. Thanks.